It is. Can you hear me okay? It doesn't sound like it's on. Maybe you should come sit by me, Brenda. Okay, welcome everybody back for our thank you, special committee on the federal 340B drug program. This is our second meeting of 2 days, and so we will be hearing testimony today and talking about some recommendations this afternoon. So we'll jump right into the agenda, and first up on WebEx, we have invited Lisa Schultz back from Century Data Systems, and she was going to talk a little bit more specific on the historical timeline. So Lisa, are you with us?
I am. Can you hear me?
We can hear you. Welcome back to the committee.
Excellent. Well, first of all, good morning, everyone, and thank you for the opportunity to once again present to the committee and guests today. So when we last met, one of the areas that the committee had a little bit more interest on was related to the historical timeline of 340B. And so today I wanted to spend a few minutes providing a little bit more context to the history of policy around the 340B program. So we'll also, as a result of that, do what I will call a decade review. Now, I wish this was kind of like doing a decade review in music and that it would be interesting and fun. However, it is policy. So we are going to make the best of it today. And then hopefully, as time permits, we've got, I think, scheduled here roughly about 30 minutes total time. We will have an opportunity for the committee to ask any questions they have or clarification that you may need. So again, my journey, I'm not going to talk a lot about this. You guys all met me at the last meeting, but I think what's important in today's context is understanding some of my background, not as a pharmacist, but more as a role that I played working specifically with the federal government as a contractor and working alongside HRSA to really understand the policy implications and some of the changes that have created this evolution in how 340B is perceived by various stakeholders, which we talked about last time. So I think as the committee is looking at 340B and how the state will make adjustments or changes or decide not to, it's important to understand where we've come from in the 340B program. And I think we have to take a step back and ask why. Again, why is 340B important? Why is it that the state is being asked by stakeholders for support in helping to administer and manage some of the 340B challenges that covered entities are facing today? And so when we look at the history and the timeline, it all goes back to the 340B law. And so I like to think about it as an onion. And so when you peel that onion back, you get to the center of the onion, and that is the 340B law, the Public Health Service Act that was passed in 1992. From that law, you then get regulations, or you get what we call more sub-guidance, and that is the Federal Register Notice process allows a government entity to provide additional insight on specific things that are contained within the law. And then last but not least, and probably less held up in a court of law, are these things that we call frequently asked questions, FAQs. These are also provided by the federal government as well as the federal government contractors. So it takes this entire onion to actually help support all of the 340B covered entity stakeholders. And a lot of what's at play today is a result of some of what we will call the gray area that is not necessarily in the law itself. However, there may be regulation, there may be guidance, and there may be FAQs. However, those things are being challenged by various stakeholders. And so we have the scenario that you are faced in, which is assessing how do you support the state and your stakeholders with good policy and good guidance on how the 340B program should be impacted within your state of Kansas. So we look at the timeline, and this is what I presented last time. So I'm just giving this more for context of history. Is you have 1992 to present day, and you will notice when you look at your screen, it has a lot more activity on one side than the other. And that is in the beginning when 340B law was passed and it was introduced to the stakeholders, a lot of things needed clarification. And that clarification at that time was done through guidance. And then in 2010, when you flash forward, some two decades later, a lot of changes happened within the program as it related to the Affordable Care Act. And so then after that, because of program expansion, you started to see a lot more activity amongst all the stakeholders on ensuring that the 340B program was meeting its intent. And so we're going to kind of go through all of these in buckets. So I will call it, we will go through kind of a decade by decade to give the committee a sense of what has happened, what has transpired over time, and how can you overlay what the federal government is doing with things that you may want to consider at the state level. So we'll start with the 90s. And in the 90s, what we have is really a couple of areas where the federal government really paid a lot of attention to, and that was guidance early on. So you heard me talk about that onion. So not the law, not regulation, but that third tier of guidance. And that guidance came in the form of really helping entities understand how to document what was considered a covered eligible location. For hospitals specifically, it was their outpatient facilities, and making sure that those outpatient facilities were eligible and that there was a format for which entities would determine which hospitals were considered eligible. Patient definition. It was in the law that the program was designed to help patients, but more specifically, that definition of a patient needed to be defined. And that was done by HRSA by defining the patient definition and the test that it took to determine whether a patient was eligible to receive 340B drugs. And a patient was not just simply going to the covered entity and being seen. It was a culmination of different things. And so that was spelled out by HRSA in guidance. We also then saw that manufacturers needed to be provided audit guidelines, because one of the things the law did was it did create the opportunity for not only the federal government to audit covered entities, but also manufacturers. And so manufacturers were provided guidelines in the early 90s as to how they would go about reviewing a covered entity for the things that they were allowed to actually look at, which was, did they utilize a drug for an eligible patient? The manufacturer could not determine whether an entity was eligible because that was the federal government's responsibility. However, if the manufacturer did feel that a drug was not used in the appropriate setting, they could trigger an audit, and this is how the government provided that guidance. The other was through ADAP, so the AIDS Drugs Assistance Program. And there was a lot of guidance for that particular program and how they could access 340B. Because as we all know, ADAP has the ability to purchase drugs, but 340B gave them another layer of a discount that the state could then use to support that patient population. And then we talk about duplicate discounts. So in the 340B program, in the law, there is a prohibition against Medicaid duplicate discounts. And I know that after me, you're going to hear from the state, specifically the state Medicaid program, and how Kansas has handled duplicate discounts and managing those. But the federal government did put out guidance for the states in making sure that a Medicaid exclusion file would be utilized to avoid a manufacturer having to pay not only a 340B discount, but to turn around and also pay a Medicaid rebate. And then we also see in the 90s a need, as the program unwinded, covered entities as well as other stakeholders realized that not every covered entity had a pharmacy, and that there was a need for access to be met, that a relationship with a pharmacy, which we will call a contract pharmacy, needed to be provided as far as guidance was concerned, so that that access could be not just at the covered entity that may not have the ability to dispense, but then it also needed to have this pharmacy relationship. And so that was defined in the early 90s. Now, the other side of this is, so that's all guidance. We also started to see our first oversight in the early 90s, and that was in relation to the AIDS Drugs Assistance Program. So the OIG actually did an audit, and they found that the ADAP program wasn't really fully utilizing 340B at its best, meaning they were really losing an opportunity for savings as it related to the ADAP program. And then I put this here as more miscellaneous because I think it's important in the context of all things 340B operationally. In the early 90s, for covered entities, they did not utilize what we call a WAC account. And for the purposes of this group, a WAC account is a wholesale acquisition cost. It's probably the most expensive way you can buy drugs at a covered entity. But in the early 90s, that was not a deliverable that covered entities used. They basically, at that time, either purchased at a 340B price, or they purchased at a group purchasing organization price, which is lower than a WAC price. And we're going to get into why this is important as the decades go. So that's the 90s. Lots of guidance, some initial start of oversight from the federal government, but this is really where we saw the beginning of what you will hear oftentimes in this program, self-policing. So covered entities knew there was a law, they knew they had the ability to purchase drugs, and they really relied on what the government gave as far as guidance, and then they self-policed, which meant they looked at the law, they looked at the guidance that was out there, and they did what the right thing was based on what information was available to them. We flash forward into the 2000s, and in the 2000s, so we basically are hopping into essentially 10 years later, we see not only guidance still coming out of the government agency, but more education and a lot more oversight. So again, early on in a new program, you always have the guidance, then you learn, ooh, we need education. And so the guidance that we started to see in the 2000s, and this relates to the last decade where I just talked about the wholesale acquisition cost requirement, we now see covered entities not only buying drugs at a 340B discount price, at a group purchasing organization price, but they're now also having to purchase drugs at a WAC price, which is a higher price, because in the 340B program for hospitals specifically, they cannot use a GPO for outpatient purchases. So they either use 340B or they use a much higher price called WAC. So that was a very big change in the program in the early 2000s. We also see more clarification from the federal government on duplicate discounts in the Medicaid program. So while they had initial guidance set foot in the 90s, which was really just to lay the groundwork for having a database, for having this exclusion file, it was found that the federal government needed to provide additional guidance to all stakeholders, from manufacturers to the states themselves that had to implement their specific policies, and to covered entities, so that they would know how to ensure they were avoiding duplicate discounts for manufacturers. Education was key. So in the early 2000s, the Health Resources and Services Administration, so the government agency responsible for the administration of the program, actually launched a call center. And this was a federal government contract through the American Pharmacists Association, and it was called the Pharmacy Services Support Center. And it was developed because the federal government needed to have an education arm at that time because there was so much guidance. It was a very new program in the context of what we see the livelihood for most government programs being less than 10 years old. People started to have a lot more questions. And so this arm was developed to really support that, and it was for all stakeholders. It did not matter if you were a covered entity, you were a manufacturer, or if you were a state needing additional guidance. This was a tool developed to support the entire community. In the 2000s, then, we then start to see even more oversight. And when we talk about oversight, it's oversight not only from the federal government, but also from some of the oversight agencies like the Office of Inspector General. So we had a couple of things happen where the OIG did do an audit of an Indian tribe. It was actually in Pennsylvania, on their utilization of 340B. And that was one of the first audits in the program that showed that there could be potential for diversion. And that particular covered entity was actually removed from the program as a result of that. We also started to see the federal government provide a lot more oversight on covered entities and how they registered in their database. So if you were to go into the database in the 90s as compared to the 2000s, the database would have looked as if though it had grown exponentially. And that is because the federal government changed how an actual covered entity needed to register. And what that means is if I was a hospital and I had 50 clinics within a child site, I had to register all of those particular sites individually. So you will often hear in the community, some people said that the program grew exponentially. Well, it wasn't that it grew, it was that it was a new requirement. There were always drugs being purchased in those clinics, but now those clinics actually had to be delineated line by line. And last but not least, we then start to see in the 2000s, one of the first testimonies from the OIG to the actual House Energy and Commerce Committee. And it was the Subcommittee for Oversight and Investigations. And this was specific to 340B. So the OIG at that time did look at the 340B program. It looked at how HRSA was administering that program and gave recommendations for HRSA to ensure that the program was operating compliantly. And again, first time. So we flash forward then and we hit the 2010s. So now in 2010, the program has been around for a little longer, and we start to not only see the need for education and guidance and oversight, there is now a new trend for judicial intervention and also regulations. So you can see the program is slowly growing and developing over time. So when we look at the judicial component, this is the first time we see two court cases, one being orphan drugs and another being Medicare Part B. And this is all related to 340B. And a lot of this activity was because in 2010, when the Affordable Care Act was passed, it actually expanded the program. And as a result of that expansion, it added rural hospitals. And one of the caveats that was placed into the Affordable Care Act was that if you were a rural facility, you had a new requirement that the other entities did not have, but you were excluded from using orphan drugs. So those are drugs to treat rare diseases. So you would not be allowed to purchase those on 340B. You would have to purchase those at a different account, as long as it wasn't 340B. The federal government at that time, to do oversight, as the agency felt it was its responsibility, was to provide guidance on the orphan drug rule that was placed into law. When that guidance was pushed out, the agency received a lot of lashback for putting out what many of the manufacturer stakeholders said was not in alignment with what HRSA's authority was, and that they went above and beyond. And so HRSA retracted that, and then they did an interpretive rule, which mainly was, hey, this is just how we're interpreting it. Again, it went into the court system, and the courts did decide that HRSA did not have the authority to publish a regulation as it was related to orphan drug, even though they said it was, really just to be more interpretive and really helping to provide additional guidance. The judge did not rule in HRSA's favor. In fact, what was so critical about that lawsuit at the time was that it actually embedded into HRSA's kind of future was how they would be perceived at doing any regulations moving forward or providing even additional guidance. Because what the lawsuit found was that HRSA really only had authority in a couple of areas. One was they could come up with standards and methods for calculating 340B price. The second was they could come up with standards for imposing civil monetary penalties. And then third was that they could come up with standards for an administrative dispute resolution process. So if there were disagreements between stakeholders, HRSA could decide that. Everything else, though, they were not really allowed to place in any type of regulation or provide authority as far as how to administer the program. And that called to question a lot of things that you'll see on the opposite side of this slide, which is the regulations. So they tried on orphan drug, that was rescinded. They did, however, have the authority for civil monetary penalties, as well as the administrative the alternative dispute resolution process, so an ADR process. However, it took a long time, as you could see, for those things to actually come out. In fact, almost a decade from the time the Affordable Care Act was passed that gave HRSA authority over civil monetary penalties and the alternative dispute resolution process. It took 10 years for them to actually put that out for notice and comment period from the community. So while all that is happening with regulations, we have a lot of judicial activity that's really tying things up. We also see HRSA still trying to provide oversight during this period where they're really being called to question as to what they can do. One of those things being audits. So HRSA does finally start to audit in 2012. So the program has now been in inception since 1992 with no audits in play. Now self-policing has pretty much gone away and audits are happening. And today they happen at about 200 covered entities on an annual basis. We also see the GAO become a lot more active. So the Government Accountability Office did 9 different studies in this decade. So a lot of people asking Congress to write in for reports on how the 340B program is operating. Is it really meeting the intent of the law? How are duplicate discounts being managed? And is HRSA providing the guidance and the oversight that they should? Congress even has 3 different reports that come out of the committees that have jurisdiction over 340B. We see HRSA starting to do a lot more activity around what we call policy releases. They did that in the early part of the decade. They then transitioned from policy releases to program updates. Again, subpar, so it's not guidance, it's not regulation, it's not law, but it was their way of communicating with the stakeholders how the program should operate in this decade. We also see a transition in HRSA's call center. So it now transitioned to the prime vendor program, which is a third federal government contractor that supports HRSA. So for the HRSA audits, they have the Bazell Group supporting them. They also had, as I mentioned earlier, the American Pharmacists Association providing them support. And now we see the prime vendor program moving not only as a mechanism to help bring value to covered entities and manufacturers in reducing the prices even lower than 340B, what we call sub-ceiling prices. We also see the prime vendor now being part of the education strategy. Again, guidance comes out, and this is when we have, as I said earlier, the Affordable Care Act expanded the program. At the same time, HRSA does put out more guidance. they put out guidance on contract pharmacy, and that is contract pharmacy no longer being a one-to-one relationship, but a one-to-many, which means for those covered entities that have, for the longest time, only been able to support one contract, they now can have an amount that is with no cap, but what meets their patient needs. And this really helped rural communities specifically, because as you can imagine, when it was a one-to-one relationship and you had a community health center in a very small town that maybe had 2 or 3 independent pharmacies, only one of those independents could actually contract with that health center. This now took that problem and put that on the back burner. Now all of the pharmacies had an opportunity to work with a covered entity and provide services and continue to take care of patients in their community. We see then another, what we called the mega guidance. It was an omnibus bill that HRSA placed and pretty much covered everything you could imagine around the 340B program. Patient definition, Medicaid, covered entity eligibility. All of this was put in guidance. It was placed out for public comment, and it was not successfully launched. Again, part of what disrupted that was the judicial lawsuits that were in play around HRSA's authority. Therefore, the federal government, and through administrative changes, through changing of the presidents, pushed back that guidance and said, not at this time. So again, lots going on. 2010s was a very busy time for the 340B program, and it's kind of what leads us to where we are today, which is we're in the 2020s, and we now see a lot of things that are trending as a result of the previous decades. And that is, I'm going to start here on the left. There's this potential federal regulatory changes as a result of court rulings and an advisory opinion that was placed out by the federal government. We start to see states taking regulatory action because the federal government does not have oversight and cannot support the covered entities as it relates to some of the challenges that they are facing. And that has a lot to do with the silence that is in the law. And that is what many states are being faced with, is how do you take that silence and turn it into something that can support all stakeholders and still meet the letter of intent of the 340B program. But we're also seeing the federal government do a lot more bulletins and give a lot more advice on actual duplicate discounts and how to prevent them. So not only from HRSA, but we're seeing it from the Center for Medicaid and Medicare Services, so CMS, which then trickles down to the states. The risk of audit findings is real. Because the federal government does do more audits today, there is a lot more oversight, and HRSA does have authority over the covered entities eligibility. They do have authority over the database being accurate. And so those are things that the federal government continues to monitor, as well as monitoring the duplicate discount prohibition and the GPO prohibition. But with all of this being said, we know we're in a government transition this year with a new administration. We're also facing a public health emergency, and all of those things have an impact on how covered entities are being supported through the transition and through change. We know with the public health emergency, covered entities right now are seeing different populations as a result of COVID, and it is changing their eligibility in the program as a result of that, because as a public hospital, they may not have seen commercial insured patients, but all of a sudden, because of COVID, they're now seeing commercial patients temporarily, and that is jeopardizing their ability to utilize the 340B program, because if they are no longer seen as a disproportionate share hospital, seeing a disproportionate share of Medicaid and Medicare, this affects them. And then as we continue to kind of move along that spectrum of trends, we see an increase in PBMs and manufacturers influencing how covered entities can purchase drugs, as well as their access to them and how they're reimbursed. And so that's where you're starting to see PBMs crafting contracts because the law is silent on PBMs, and the HRSA, as the government agency, does not have the authority to say yes or no. This is now creating the stir of PBMs running forward and creating what we will call discriminatory contracts for covered entities only. And then the flip side of that is the manufacturers, because they question HRSA's authority, are now deciding, well, we don't have to do contract pharmacy because it's guidance. And well, HRSA, you really don't have authority. So we're going to stop selling drugs to the covered entities and their contract pharmacy partners. So, and there's some judicial opinions that have come out just within the last couple of months from lawsuits that were filed by manufacturers against HRSA as it relates to the limitation of contract pharmacy with differing opinions. So we have 3 different jurisdictions that are hearing court cases. 2 of them have been in favor of covered entities. 1 of them more recently has not been in favor of covered entities. So again, the federal government is pretty much at a standstill. And so no one's really able to support 340B covered entities with a true response as to what should happen now based on the environment that we're in. And then last but not least, we're also seeing a lot more on the retail specialty pharmacy side, which is the contracted pharmacy space, mandating to the covered entities the types of technology solutions they should use, and really kind of directing how they will manage their programs, while the covered entity still remains 100% responsibility for the 340B program. So with that, I'm looking at our time here. It's at 11:36. We do have some time for questions. We covered a lot of ground. We covered basically the 90s, the 2000s, the 2010s, and the 20s. So 4 decades of time. And if there are questions from the committee, I would be happy to take those.
Okay, thank you, Lisa, for that. I'm echoing. For that detailed explanation. So we'll take questions now. Senator Gossage.
Thank you, Madam Chair. Just 2 quick questions. Earlier, you mentioned that there was a definition that was created, I think it was on when we were talking about the 90s, for a patient who is an eligible patient. Do you have that definition for us?
Yeah, and I can actually get that to the group. It's a 3-pronged test. So to be the definition of patient, you have to be seen at an eligible location.
Okay.
And by an eligible provider. And the responsibility for care has to be with the covered entity. So we basically call it a 3-pronged approach. And so again, location, provider, and responsibility for care. And I can provide that guidance if that would help the group as well.
So basically, anyone that comes to that hospital.
Correct, as long as they are seen as an eligible location on the Medicare cost report. So
Okay,
you, myself, anyone would be considered, as long as we're there with care by an eligible provider, we would be considered an eligible 340B patient.
Thank you. And my second question, and last question, is on the 2000s. It mentions the database changes to expand on child site listings. Would you explain what that is?
Yes. So if you think about a hospital and how their Medicare cost report is filed. So on let's just say you are a large disproportionate share hospital. You have your main hospital. You also have an ambulatory care center that's attached to it. Maybe there's a bridge, maybe there's a walkway, and the federal government determined that, well, we really need to understand where you're purchasing drugs in this program, not just that it's the hospital, but if you have other, what we'll call child sites that are on the Medicare cost report, which are eligible for the program, we want to have a better understanding so there's transparency where drugs are being utilized. And so at that time, you may have just had the hospital on the federal government's website. Now, not only did you have the hospital, but the ambulatory center that was next door that was eligible, maybe it had 40 different services that were provided within that building. Let's say it was dermatology, it was some oncology, it was primary care. And all of those sites had to be listed in the database as separate sites. While they still were part of the parent, they were considered child sites. And again, that was for transparency.
Thank you. Thank you, Madam Chair.
Senator Pittman.
Thank you, Madam Chair, and thank you for being here and giving the vast history of this program, and once again, getting us focused in on this complex issue. I've got a question. You know, we have a lot of discussions in the last session just about the transparency of where the money goes. And there were a bunch of audits done in the 2010s, you know, by the government. And I see that you work for Century Data Systems, and so you obviously know about data and transparency.
Yes.
Is it, could you just talk briefly about how transparent, how does, if one were to say this is non-transparent or transparent, would you say that, you know, can manufacturers find out where and how much money has gone to each of these hospitals? Are they able to be audited, you know, on demand, or is the transparency limited only to the government audits and that's it? Can you just speak briefly about the transparency of where the money goes? Because that seems to be something that definitely gets in people's craw.
Yes, and transparency has been on the radar for probably the last 5 years as a concern, and I say it's a concern by more of the opposition of, we understand we participate in this program, we sell our drugs, how are those drugs being used? And today, as part of the audit process, the federal government does not go in to audit what did you do with the savings. The federal government goes in to audit, are you administering the program according to the law and what they have the authority to actually audit. So what was put in the budget this year, the federal budget by HRSA, was they asked for authority to look more at transparency from the savings component, meaning how are the savings? So we get that you're purchasing drugs, but how are those savings being utilized within your community? And so that's an ask that has been made. And that ask is not the first time. There's been several asks over the years to give HRSA more authority over the savings and making that part of their audit process. But today it is not. What we see today is that covered entities voluntarily report. So a lot of them have what's called a 340B impact report. And they provide that sometimes on their websites as part of their community benefit. They share that information to let the community know what it is that they're doing with savings that they've generated from the 340B program. However, it is not a requirement by the federal government that they do that today. And so I think that's the ask that you probably are hearing, is that some people really just want to understand how the program is being utilized and have that built in to be more transparent across the board versus, well, hospital A volunteers it, hospital B says, well, I don't have to, so I'm not. So that's, I think, maybe what you're asking about and that you've been hearing of.
Representative Wolfmore.
Thank you very much. Thank you for your help today. I just want to make sure I understand something. So the PBMs can craft these contracts that sort of interfere with the ability for the covered entity to get the discount. And so then the federal government can't do anything about that. So the covered entity, they don't have what they would risk losing the business if they didn't accept the contract. Am I understanding that?
Yeah, you're understanding that perfectly well. So yes, so as a covered entity, I get a contract. My contracts office receives a contract to do business with a PBM. The PBMs have learned how to utilize the federal government's database to say, well, we realize you get 340B, and because we realize you get 340B, we're going to provide you a different contract, and we will reimburse you differently because of that. And I think when we look at the intent of the program, the intent of 340B was to support the hospital so that they could stretch scarce resources, not to support the PBM, reduce their reimbursement rates. And basically the PBM is getting the advantage in those cases where the covered entity signs that contract. The PBM is getting the benefit of a reduced reimbursement to them, which again is counter to the original intent of the program.
And so,
And there is no recourse for that.
and so that is then why, since there's no federal government protector, why states are stepping in and trying to protect the program. Okay.
That is correct.
Thank you very much. Thank you, Madam.
Senator Hildebrand.
Thank you, Madam Chair. I was just sitting here minding my own business next to this doorway, wondering if I need to leave. But you mentioned something that popped a question for me. You said that the 340B program was instituted to support hospitals and not PBMs. Wasn't it the true reason the 340B was for low-income people?
The actual, if you look at the language from Congress at the time when the program was put into play, it was decided and defined as the ability for the covered entities to stretch scarce federal resources so that they could serve more eligible patients. And that is a direct quote from the committee that at that time, actually from the House, when they put in the legislation.
Senator Hildebrand, you can continue.
Thank you, Madam Chair. And what is your definition of eligible people for the 340B to serve those eligible people?
Yeah, and the definition for eligible is patient definition. And patient definition is defined by HRSA through their guidance, where it's that three-pronged test that we talked about earlier in supporting patients that are eligible, that meet that criteria: provider, the actual location, and having responsibility for care for that patient.
So, not to debate this issue very much longer, but you put the emphasis on the first part. I would put the emphasis on the second part, that it was for the patient, that benefit of the low-income patient. So thank you, Madam Chair.
So Lisa, when we're doing definitions, when you talked about the expansion with the ACA that included our rural hospitals, what's the eligibility for a rural hospital? Is it all of our critical access hospitals in the state?
Yes, so the rural definitions are determined by the Medicare cost report filing status. So for rural hospitals, the eligible hospital types are a critical access hospital. So a critical access hospital, by nature of their designation, is eligible to participate in 340B. Rural referral centers, they are also eligible to participate in 340B, as well as sole community hospitals. Now, the difference with a sole community hospital is, if you look at taking back what a normal DISH hospital is, their eligibility criteria are that they meet an 11.75% disproportionate share. Sole community hospitals have an 8%, so theirs is a bit different. And that's a differentiator for a sole community hospital. So sole community, rural referral, and critical access hospital.
Okay, thank you. Representative Carpenter.
Thank you, Madam Chair, and thank you very much for being here. It's kind of like we get into up here, this is drinking from a fire hose, but anyway, I do want to go back to what Senator Gossage said about the patient. So the patient just has to be served by, go over that again, please, for me. So there's no determination whether they're uninsured or on Medicare or anything like that for a patient, is that correct?
That is correct. So the patient definition does not look at uninsured or underinsured or Medicaid or Medicare. What it does is it defines a patient at the covered entity as being eligible for that actual site of care. So I oftentimes tell people when 340B was developed, it was not a patient assistance program. It was a covered entity assistance program so that the covered entity could determine how they support their patient population. And if you look at public hospitals, they have discount programs, they have criteria for which people can apply for eligibility for either no copays or tiered copays or discounts off of a set price. And those are all written into hospitals' policies for how they serve those types of patients that really cannot afford their medication and need that support. Same thing happens with grantees. So grantees, which would be like a community health center, they have criteria around providing sliding fee scales. Again, all based on patients' ability to pay. And specifically in that side of the world, they look at federal poverty levels. So they look at the FPL, what percentage are you, and that determines the patient's ability to pay.
Okay, so if that happens and the person has full coverage insurance that pays that bill, then, but the hospital gets reimbursed at the 340 rate, so that's the money that we're talking about here that the providers are using to supplement
Correct.
their community care or anything like
Correct.
that.
Correct. It's to supplement their discount programs they provide. It's to, perhaps it's to buy a mammography machine. It's to, again, however that community needs assessment is how the hospital determines how they are going to utilize those funds.
And are they ever going to utilize those funds by, excuse me, by a discounted rate to that patient that's uninsured?
Absolutely. That very well could be part of that hospital's program, that they provide discounts or free drugs.
And how would we know that?
Most of the hospitals have what's called a community benefit report that they put out, and they actually outline some of those programs and how much money goes into providing those types of discounts.
But there are no names attached to that because of HIPAA and other things like that. So really, we have no idea.
Correct. Yeah, not specific to patient. What you have is the information that a hospital would give you collectively as a whole that they have discounted.
Thank you. Thank you very much, Madam Chair.
Senator Erickson.
Thank you, Madam Chair, and thank you for your testimony today. Just a quick question. Is there any measure of the efficacy, if I could get it out, of this program pre-1992 to currently? Is there a way that we have data that measures the accessibility and affordability from the patient's perspective?
I'm not aware of a study that has been done on that, so I could not tell you if the program has changed as far as the accessibility.
Senator Gossage.
Thank you, Madam Chair. Do we know which Kansas hospitals are, I would have to say probably not included in this list, probably most are. Do we know? Do we have a list of those?
I have seen that, but I don't know where I saw that. Does anybody?
I think that would be good for this committee to have. And then one last question, if I may, from our conferee. So the question I have there is, you stated earlier that the federal government cannot step in where they feel like the PBM or the pharmaceutical benefit manager is not reimbursing at the rate. Of course, the term reimburse means we're going to pay you what you got paid. We're going to reimburse you. So what they're saying is they can't keep them from reimbursing at the level in which they're paid. They want them to be reimbursed like they're reimbursing non-340B hospitals. And the federal government can't do it. Why is that? But the state can. I'm trying to understand.
Yeah, so HRSA does not have the authority in that particular area. So that is not something that the law gave them the authority. So if you were to ask the federal government contractor that same question, they have a standard response that they give to any covered entity that asks that question. How come HRSA cannot? And it's because they do not have the authority, and they ask that covered entities work with the PBM in as good stewards to negotiate a price. And that is the only advice that they give them. But you have to understand, some of these covered entities are very small. They do not have the bandwidth, they don't have the reach for really negotiating with a PBM. So it oftentimes becomes sign it or don't sign it, and you won't have the reimbursement.
Thank you.
Representative Tarwater.
One follow-up, just a short one.
Thank you, Madam Chair. And thanks for being here with us today. You were asked a couple of times about the intent of the program, and you said a few times that when it was developed, it was for covered entity assistance, and it was to be used for indigent care or care for people that needed more than others. And but you've always keyed on when it was developed. So are there other interpretations since its inception that think that it should be for the patient, or is it still for the hospitals?
I mean, today, as we look at how the program is being operated, it is as a covered entity program. Are there people in the community that believe it should be otherwise? Surely, yes. And I'm sure that those are people that you may be hearing from as well. But I think hospitals would tell you they are helping their patients who can't afford medications, and that the program is operating as intended. However, the parts of it where they are looking for support is how to manage things that they do not have control over, which is the PBM industry, as well as some of the manufacturers that are determining how the program should look today.
Okay, so that's kind of what I thought. Then, so I noticed that you work for Century Data Systems, and it seems to be one of the more premier data companies for 340B program. And I went to your website, and it looks like you can take a real deep dive on all the data for all of the end users on this. And so, and there's been a lot of questions today on whether or not where the money goes and if it does actually benefit the end user or the patient, the needy patient. They're self-reporting. I agree with Senator
Yes.
Pittman that, I agree with Senator Pittman that we probably need a lot more transparency to this. And I don't know that self-reporting is the way, but it seems like you have a tool so that if we were to pass a bill, or someone was to pass a bill that would want to take a deep dive into how the hospitals were managing these dollars, it would be pretty easy to get that information out of your system, wouldn't it?
We would definitely, as a technology company, I mean, we know what the gross and we know what the net is for transactions that are eligible for 340B. What we would not, as a technology company, be able to tell you is, well, what happened with that net? What happened to that money? That is something that a hospital, through a lot of their impact reporting, has been able to share, because that's in their financial system, and how they manage where their funds actually go and how they spend any of that net, what we will call, so for the sake of calling it, where that net profit would go to support their programs. But yes, lots of data.
Yeah, well, when you say you can take a deep dive, then it's just on whether or not a drug qualifies. It's like a spreadsheet, or is it more to it than that?
Yeah, so when you look at what the tech company does, like a company like Sentry, we look at all the claims that are coming in. We know what the switch is coming across as far as what is the insurer providing as the reimbursement. We know where they're coming from, what eligible location. We know whether they have Medicaid, Medicare, and frequency. You can actually look a lot at adherence, how adherent is a patient who is typically in an underserved community, may not be as adherent, that your patient population is a lot more difficult to care for. But as far as, again, what happens with that money, that is not something that a technology company would necessarily have today unless a covered entity had reporting mechanisms within their financial system that provided that type of information.
Okay,
And that's been one of the bigger challenges with transparency is we've got a lot of data. We know how much a drug cost. We know how much a drug was reimbursed. We know what part of a hospital it's coming from, so we can tell you where most of the benefit is seen within a hospital. But as far as what is happening with the money that is netted out of that, that's not within the technology systems. It would be in a financial system within a hospital.
Okay, so we would be able to at least, or an auditor would be at least able to tell how much, if any, of the discount went to the patient as far as the sale of the drug.
Correct. Yeah, you would get a copay. Like, what was the copay? Patient responsibility, that would come across for sure. So you would have a difference of what you were reimbursed. You would know what a patient paid or what a patient did not pay. Many of the systems, like we offer what we call a drug discount card, which is for the hospital that does want to provide discounted drugs to their patient. Those systems exist, and those would tell you exactly, here's what it cost, this is what the patient paid, and we have a lot of hospitals that utilize those types of programs to make sure that they are offering a discount plan.
Okay, great. So it looks like we would be able to get most of the information out of a data system, and then it would be up to the
Yes.
hospital to show us where the dollars were going and whether or not they were just going to run the hospital or if they were going to actually be passed on to these end user patients. Okay, thank you very much.
Correct.
Representative Carpenter.
Thank you, Madam Chair. I have questions now from the previous representative, Tarwater. Would you have baseline information then that would, say an average hospital and their 340B uses would carry along, and then if a hospital went above and beyond that, that would also flag as far as the percentage goes of the usage of a 340B program?
When you say usage, maybe help give me a little bit more definition of what it is you're asking.
Of the drugs. For instance, if a hospital was using a lot more 340B program drugs than even the area that they serve.
Yes. I mean, we know purchase volume and comparatively can do comparative analytics between hospitals and whose volumes are higher, lower on average.
Okay. And then the other question, just a very quick question, on slide 10 that you showed earlier, on the bottom there, on your slide, it had HRSA call center managed by Prime vendor program. The next bullet on the ones that we have here in our packet say state law, PBM, anti-discriminatory language. So is there a reason why this one has that and yours did not have?
Slide 10. Let's go back to slide 10. So yours does not have the last bullet, state law?
It has state law. The one I saw on your screen did not have state law.
Okay. I'm sharing it now. It does have it. It might have been due to a click, is my guess, because these are all bullets. So that might be why.
Okay, thank you.
Senator Pittman.
Thank you for the second time here. Just, I want to clarify, Representative Tarwater brought up a good issue, and, you know, I guess what just to kind of summarize, where Medicaid might be a program instituted by Congress to target individuals who meet a certain poverty level and target their health care and some of the prescriptions. The intent of this 340B was separate than that. It was a different program set up to covered entities, support them with these pharmaceutical discounts from the pharmaceutical companies, which step in, and they, you know, obviously they're performing a service to our country by doing that. I appreciate that.
Yes.
To his point, though, in Congress, they've never tried to change that in the last 30 years for the intent. I know you mentioned stakeholders and wanting to change it, but really Congress has never stepped in and made a concerted effort to change the intent of this program. Is that correct?
That is, yeah, I will tell you, Congress has introduced lots of bills within probably the last 5 years. It's the most activity we've actually seen in this program from a congressional standpoint as far as the legislative process itself. However, those bills have not made it into law. So they have not passed both House and Senate to actually make it to a point where those would be enacted.
Okay.
And I think that's where we're stuck is if Congress, and many of the judicial lawsuits this year have said, if Congress would like to intend to change the program, Congress needs to change the program.
Okay, thank you.
That is yet to happen.
I just wanted to make sure about that. Thanks.
Representative Landwehr.
I'm not sure I want to hear either one of us twice like that. So, thank you, Madam Chair. So what we're dealing with here today is that under our current law with the 340B is entities can and do charge considerable markup on the 340 price drugs. Would that be correct?
Covered entities do charge what their running reasonable rate is. Yes. They do that as they have to in order to contract and reading of the plans. They have to actually have a usual and customary charge, which may be marked up on the price in which they purchase a drug, which is traditional.
Okay, we couldn't understand anything, and our computer folks are sitting here trying to figure out what might be happening. Is that on her end, you think?
You can try turning off her video, or you can just try saying it again.
Yeah, either try to say it again, or maybe you turn off your video and say it.
Yeah, so your question is, do covered entities charge marked up rates? Make sure I have that correct.
Yes.
Yes, so what most covered entities do is they have something called a usual and customary charge. You have to have that type of system in order to contract for all types of insurance plans. What is your usual and customary? Yes, it may be a markup. However, covered entities do offer what they call discounts from what their usual and customary charges are. And that's in their policies.
But several of the drugs, and including insulins, are available through 340B for, you know, pennies per unit. And then there's no control whatsoever of the markup on those drugs. Is that correct?
Hospitals have policies around what their markup is on their charges. But there are usual and customary charges, which are typically, we base those off of either an AWP, an actual wholesale price, or in some cases, as I mentioned earlier, a WAC price, which is a wholesale acquisition cost, and those are typically a percentage of a mark down from that price.
So perhaps then, one of the issues that we face in this program is that even uninsureds could be paying that marked up price and not getting the benefit of a 340B. Would that be correct?
If they did not go through the hospital's program or not having insurance, and every hospital has a program designed specifically to support those patients that would fall into that particular category you address. If that patient does not provide that hospital the documentation, the things that are asked for when a patient does come to you and applies for a discount program, they could fall in the cracks. Absolutely.
If the patient applies for this, correct?
So the question you said was that a patient, well, maybe they have no insurance. They go to a hospital, and the hospital, through their registration process, wants to make sure that patient can either qualify for Medicaid, qualify for Medicare, or any and all types of discounts that that hospital might be able to get for that particular patient. But that patient oftentimes is required to provide documentation. They may be asked to provide income. They may be asked to provide proof of residency, all types of things. And there are cases, I worked in a hospital, I worked with patients very much like this, where they may not provide you their documentation. They may not have it. They may not understand how to get it. They may just have things in their life that prevent them from getting that paperwork to the actual hospital, where initially they may be charged a usual and customary fee until they can get through that paperwork process. But the hospital's intent is to make sure that every patient that qualifies for any kind of discount is going to get that discount. But yes, there are barriers.
So unless the individual has the documentation, and something tells me most of the time they don't, they're not going to get the discount, and then they could be charged whatever the price is that the entity has set for that product. So an uninsured, underinsured individual would be paying retail or possibly even above retail for a prescription drug that was sold to the entity at a 340B cost. Would that be accurate?
It is a possibility that that could happen. However, most hospitals, as their collection process, are not collecting that money up front, and they're going to work with that patient before they actually send that patient a bill that would be at usual and customary. Again, I would defer to specific hospital policies on how they handle billing and collection. And I think that probably would be the better route for asking someone, maybe from a covered entity, how they manage that process.
Okay, and I think, Madam Chair, one of the problems that some of us are running into is getting the information that we request, from some of our hospitals as to, what those amounts are that they receive under this program in force, because we're not dealing with pennies here. I can tell you one entity that's 80 million plus is what they receive under this program. Is that good, bad? Are they doing anything? I don't know. But I think that's a start. So that might be something that that the members, I think, are going to have is, really what is being charged? How do we know how many of these uninsured and underinsureds are actually being, taken care of, which was the original intent of the program? So there's my comment. Thank you.
Thank you, Representative. And I will say, I've asked for that information as well. I think the hospitals would love to share those contracts and how much they're receiving under this. I think they are blocked from doing that. We'll ask the hospitals when they, no, it's not a matter of opinion. It's in their contracts. They're not allowed to share it. Representative Wolfmore.
Thank you very much. So the rates charged for those drugs are what's negotiated with the insurance companies, correct? Those aren't just hospitals marking up drugs to any degree they choose.
Yes, so a hospital will have what they call a usual and customary charge as a baseline. And then let's say you have insurance, or it's Medicaid, or it's Medicare. Those are negotiated rates that those patients then have patient responsibility for. But if you don't have insurance or a federal government program that covers you, then you are at the realm of the usual and customary rate, and then the hospital's policy around how they discount depending on the patient ability to pay then kicks in.
Is that okay? And then another question is, so are hospitals subject to federal government audits of these programs?
So your question is, are the hospitals subject to a 340B audit?
Yeah, yes.
Yes, they are. Yes, so hospitals are subject to audit today. The federal government today, through their government contractor, has about 200 covered entities that they audit annually, which if you look at how many sister covered entities, or what I'll call child sites, it's roughly, they have a little over 5,000 actual sites that are audited by the federal government.
Thank you,
And that
Madam Chair.
includes their pharmacy. Yeah, that includes their pharmacies.
Representative Tarwater.
Thank you, Madam Chair. So earlier you had said that the federal government can audit these hospitals, but they do not look at how the money is spent. Is that correct?
Correct.
Thank you.
Senator Pittman.
Thank you for my third time at this, and I'm sure we're going to get to the next conferee, and I appreciate your patience on the call here. Just curious, we have a lot of issues we're expressing around transparency. Do the PBMs actually, can they be audited, and are they required to also kind of document how their businesses, where their payments come and go? Are they subject to the same kind of transparency as some of the other entities, or not?
I am probably not an expert on the PBM's auditing. I know that there has been a lot of discussion this year through Congress around building more transparency with PBMs, but I wouldn't be able to tell you directly whether or not they're subject to.
No problem. Thanks.
Okay, Lisa, I don't see any more questions. Oh, Senator Gossage.
Thank you, Madam Chair. We keep using the term covered entity, and I'm trying to understand why. I mean, they're hospitals. Is there a reason we're not using the term hospital, or that the law doesn't use the term hospital?
I use the term covered entity because covered entity in 340B comprises about 18 different types of covered entities. So hospitals are one type, and there are, remember here, I think there's now 6 different types of hospital entities. So children's hospitals, DISH hospitals, the rural hospitals I referred to earlier. And then the other covered entity types are what we call grantees. And those are community health centers, or you may hear them termed federally qualified health centers, FQHCs. It's Ryan White programs. It's STD, TB, a lot of what we'll call smaller organizations. I think for the purposes of 340B, we oftentimes talk a lot about it as hospitals in general terms, but there are more than just hospitals that participate in the program.
So a health center that does not have the designation of hospital would be the other covered entity that would not be included under the definition of hospital. Is that right?
Correct.
Okay, so it's kind of like using the term provider, which is for expediency. A lot of doctors do not like the term provider, but that can include hospitals, doctors, specialists, et cetera. All right, thank you.
Yes, that's correct.
All right. Thank you very much, Lisa, for joining us again, and thank you very much for answering all of our questions. Okay.
Thank you.
So we'll move on to Sarah Fertig, and she's joining us via WebEx. And she's giving us an update on the relationship of Medicaid and the 340 program.
Thank you, Madam Chairman, and good morning, committee. My name is Sarah Fertig. I'm the State Medicaid Director with KDHE. I have a very short slide deck for you this morning, so short, in fact, that I don't think I'm going to share my screen because it's only 2 slides of substance. So our slides have the big CanCare logo on them, so they should be easy for you to identify. And I'm going to give you kind of a brief overview of how the 340B program intersects with Medicaid. And as you've learned during your time on the committee, there's a couple of laws that affect 340B and Medicaid. So in 1990, there was a federal law passed that requires drug manufacturers to pay a mandatory rebate for each unit of their product that is shown in Medicaid drug utilization claims data. So they have to pay a mandatory rebate on all Medicaid drug claims. And we use the rebate revenue to help pay for the Medicaid program. Then a couple of years later, a federal law created the 340B program, and it included a provision that prohibits a double dipping of discounts. So you cannot receive a Medicaid drug rebate on the same claim for which a 340B reduced price is received. So no double dipping of discounts. If a 340B drug is administered to a Medicaid beneficiary, the Medicaid program cannot also claim a drug rebate on that particular claim. And the law allows states some flexibility in how they choose to administer the 340B program in regards to Medicaid. And so states have the opportunity to choose to allow or not allow, or decide when and where to allow drugs purchased through the 340B program to be used for Medicaid beneficiaries. And in Kansas, currently, we only allow 340B purchased drugs to be used as physician-administered drugs and covered entity-owned pharmacy claims. And those are the only instances where 340B purchased drugs may be used for Medicaid beneficiaries in Kansas. And we also receive lots of questions about what the pharmacy experience is like for a Medicaid beneficiary. So at the bottom of my first slide, I included some information there on how that works. So for Medicaid managed care or CanCare members, there is no copay at the point of sale for pharmacy services. And for the 4 to 5% of Kansas Medicaid members who are on the fee-for-service side, so they're not in CanCare, there's a $3 per drug copay for those individuals. Now, on the second slide, I provided a little bit more information about the dollar figures, how this adds up for the Kansas Medicaid program. So as I previously indicated, we currently exclude 340B covered entity owned pharmacy claims from rebate invoicing. We also exclude physician administered drugs or PAD claims from rebate invoicing. And I provided some data from calendar year 2020 as to what that means. So for covered entity owned pharmacy claims, the Medicaid program did not invoice for $4.72 million worth of claims because those were claims where a 340B discounted price had already been received, so we could not invoice the drug manufacturer for a rebate for those claims. And for physician-administered drugs, the rebate loss there was about $3.3 million. So in calendar year 2020, collectively, that was about $8 million of drug rebates that we did not receive as revenue. So what this means for the Kansas Medicaid program is if there is an expansion of the 340B program in a way that requires the Medicaid program to acknowledge more 340B drug claims and thereby reduce the number of claims that we can submit to drug manufacturers for rebate, that will cut into our drug rebate revenue. And so based on our calendar year 2020 data, if we saw a 10% decrease in the number of Medicaid drug claims that we could submit to drug manufacturers and receive a rebate on, that would have resulted in about a $21.1 million loss of rebate revenue. And I would also add that in addition to the mandatory rebates that federal law requires drug manufacturers to offer to Medicaid programs as a condition of participating in Medicaid, we're also able to negotiate supplemental drug rebates, which are offered in exchange for the state giving preferred drug listing preference for their Medicaid program. So this is on top of the mandatory rebates. And in calendar year 2020, we received about $11.6 million in supplemental rebates through that program. So, Madam Chair, that concludes kind of my brief remarks there. I would be happy to stand for any questions the committee may have.
Representative Wolfmore.
Thank you very much for that information. So that number that you're giving us that's all funds, right? Not just SGF?
Yes, thank you, Representative Wolfmore. And Madam Chair, that is correct. The figures that we have on these slides represent all funds, state and federal.
Could you give me a better idea what SGF would be? And of course, I know this depends on what the legislation looks like, and we haven't determined what it's going to be, so that could drastically decrease the fiscal note, but could you give me an idea of SGF?
Certainly. Typically, the federal share for Medicaid costs is about 59 to 60%. So about 40% of these amounts are the state share of the rebate revenue.
Okay, thank you very much. Thank you, Madam Chair.
Senator Pittman.
Thank you, Madam Chair. I'm a little slow a lot of times, and thanks. When we say if the 340B program is expanded, we're going to cost Medicaid $21 million in terms of revenue. I think what you mean is if the legislation that was proposed previously happens, is that kind of what we're dealing with here? It seems like there's an assumption I'm missing here. We haven't really talked about expanding the program so much here. We're just kind of reviewing. So I think there's an assumption. Can you just kind of let me know what's this based on? And I'm sorry, I'm just coming up to speed. A lot of other folks know what's going on, and they've been inside the health committees, and I appreciate that. Where is it that we're going to lose $21 million? And is there something that we could do in any proposed legislation not to have that happen?
Those are great questions, Senator. Thank you. And Madam Chair, our testimony today is not in response to any particular legislation that was passed. We just wanted to make sure that the committee was aware that that's how 340B intersects with Kansas Medicaid. So currently, every year we exclude a certain amount of drug claims from our rebate invoicing. That's kind of our status quo. And so if there are changes made to the Medicaid program that would require us to exclude more of those claims from rebate invoicing, it will negatively impact the revenue that we receive from the drug manufacturers that goes to help pay for the Medicaid program. So the example that we give on our slides is just using calendar year 2020 data. Each year we receive slightly differing amounts of rebate revenue because it's claims based. So if there are more drug claims in a particular year that we can claim a rebate on, we'll receive more revenue and vice versa. So the example that we gave is just based on calendar year 2020 data. And theoretically, if we were to receive 10% less in rebate revenue because we had to exclude more claims from rebate processing, that's what the fiscal impact would have been for calendar year 2020.
Okay, so this doesn't also, just making note, being very clear, this doesn't talk to Medicaid expansion either, right? If that were to come about, that this has nothing to do with that either, right?
No, it does not. This relates solely to the 340B program and how many claims we're able to submit for rebate invoicing for drug manufacturers and how many we have to exclude from that invoice because it's already been subject to the 340B discount. So the no double dipping rule.
Senator Gossage.
Thank you, Madam Chair, and thank you for being here. Just trying to understand, so if we have more drugs that are subject to the 340B, then, and you mentioned that in Kansas, it's only the physician-assisted medication, so what we would think of primarily are Medicare B type medications. So if that's the case, what you're saying is prior to 340B, they were able to get the rebates on those, and now they are not. Is that what I understand you saying?
That's a great question, Senator. And Madam Chair, so there was a couple-year period when the federal law was in place that required drug manufacturers to give Medicaid programs rebates on their drugs that were delivered to Medicaid beneficiaries. So there was a couple-year delay between that law being passed and the 340B law. So Madam Chair, my assumption would be that during that kind of 3-year period in between when those two laws were passed, that there probably were more drug rebates that were able to be received by Medicaid programs before 340B was passed.
So then, when 340B was passed, and again, it's only affecting those drugs that are physician-assisted. So I'm trying to understand, so you're saying there $8 million worth of rebates that would have been received had it been on the physician-assisted drugs. It has nothing to do with other, like the prescription drugs one would pick up at the pharmacy or at the hospital.
Madam Chair, so to answer the Senator's question, we currently exclude physician-administered drugs and also drugs that are dispensed by a covered entity-owned pharmacy. So to use a local example, so to use a local example, Stormont Vale is the hospital right down the street from the Capitol. It is a 340B covered entity. They have their own in-house pharmacy. So all of the drugs that are dispensed to Medicaid beneficiaries from Stormont Vale's owned pharmacy, we exclude all of those from rebate invoicing too. So it's not just
far more than
physician-
just the physician assistant. That makes more sense. And then my
Yes.
final question, if I may, Madam Chair, is that, so if the Medicaid program, and you have a certain amount of dollars that come in from rebate, and then you have a certain amount of dollars that are going out to pay for medications for Medicaid patients. So if you have a Medicaid beneficiary that is to be receiving this lower price through the 340B program, is that not also a savings to Medicaid? I realize that's less revenue coming in, but isn't it also a savings on the other end?
That's a good question, Senator. I haven't really thought about it in that fashion before. So I don't know the answer to that question, Senator. I will, that's a good one. I will have to research that and get back to you.
Thank you. Thank you, Madam Chair.
Senator Hildebrand.
Thank you, Madam Chair, and Sarah, thank you for your testimony. Just a quick question and make sure my math is correct. If 10% is a 21.1 million loss, then our total is around 211 million is what we get rebated from pharmacies for our drug rebates.
That's a good question, Senator. Thank you. And Madam Chair, typically every year our rebate collections are a little bit different. It's usually a couple hundred million in rebates that we receive. So yes, based on calendar year 2020 data, about 10% additional rebate loss would have added up to about 21.1 million. So in calendar year 2020, I don't recall the precise number, dollar figure of rebates, but I believe it was around 240 million in CY 2020. It's a significant sum that goes to pay for the Medicaid program.
Sarah, how do, when we get the rebates, how do the covered entities, do they receive any of those dollars, and how do we know how those are used?
That's a good question, Madam Chair. So what the rebates that I'm talking about, these are the ones that go directly to the state. They come to the state, and it's a requirement under federal law that drug manufacturers offer drug rebates to state Medicaid programs, and that goes to offset the state and federal cost of administering the Medicaid program. So the drug rebates that we're talking about, it's only goes to the state and to help pay for the Medicaid program. I do not know if covered entities themselves receive rebates on the side. I don't know that.
Gotcha, thank you. Senator Miller, or Representative Miller.
It's not an insult. Following up on Senator Pittman's questions, if I understood your answers to his questions and the point of your testimony is that there are things legislatively that we might do that would affect the state's bottom line, but you know of no proposed changes at this point that would do that. Am I on the right track? Is that a good question or a great question?
I'm going to say that's a great question. So, Madam Chair, I know that there has been some legislation introduced in recent years that concern the 340B program. And, you know, to answer the question, really, if there's legislation that would require the Medicaid program to exclude more drug claims from the rebate invoices that we send to drug manufacturers, that would have a fiscal impact on the Medicaid program. If there's legislation in this arena that does not require us to increase the number of drug rebate claims that we do not send to the manufacturer, then it would not have an impact on our program.
And if there is legislation that rises to the level of a hearing, you'll be all over it making that point, right?
Madam Chair, we do monitor legislation pretty closely on anything that would affect Medicaid finances. We do.
But you'll be testifying in a similar fashion to what you're telling us, that that legislation has a negative impact on the state's bottom line. If it,
we would testify accurately. If we're asked to put together a fiscal note to estimate the cost of any particular legislation, we would do that accurately.
Thank you, Madam Chair. Thank you.
Further questions? Okay, thank you, Sarah.
Thank you.
Okay, we will now welcome the pharmacy benefit managers with the 340B program that Alex Summer from Prime Therapeutics. Welcome to committee. I'm glad you could make it this time. I'm sorry you had difficulties at our last meeting.
Got me? All right, thank you. All right. So what I want to do is I have some slides that I think you guys in the handout. Really, I'm going to speak to, I think I'm going to kind of flip the order a little bit and speak to something because we just hit on it a lot with the Medicaid director. And I kind of want to highlight some of the points that were made there. And that was the discussion around really what we're looking for here is simply the ability to manage the 340B program or kind of respond to the 340B program in a similar fashion as the Medicaid program does in the commercial space. The way the Medicaid program talked about the loss of rebate dollars affecting the state's bottom line, that same thing applies in the commercial space. Rebates help fund or lower premiums, or hold premiums down the same way the Medicaid program used those dollars to administer that benefit there. So I think I really want to highlight that point that, again, we're looking for parity and nothing more. So in this legislation that would go to, you know, we can't carve Medicaid out and can't change, you know, the way, say, you know, commercial has to manage one way, Medicaid another way because it's going to affect Medicaid rebates. Well, that same impact is going to apply in the commercial space. So that's why I just wanted to start there and really highlight what the Medicaid director just spoke to. Now, as we've talked about this, there's been a lot of discussion around the covered entities. Rightfully so. The statute is directed at the covered entity and the provision of drugs from manufacturers to those covered entities. What we've not discussed a lot are the contract pharmacies. And I think that's where we run into, you know, that's the genesis of the issue that has this committee meeting in the interim here this year. In 2010, when the multiple contract pharmacy guidance was released, that's when we started to see, that's when these problems began. The program exploded beyond what it had been for the first 18 years. So here, I don't want to belabor the point of what the purpose and the requirements are of the 340B program. You guys have had a day and a half of that already. But what I do want to focus on again is that in that statute, they spoke to, or Congress spoke to, again, covered entities, manufacturers, and were silent about the contract pharmacies. They were a creation of the agency later on, and again, have continued to be poorly defined throughout the, since 2010, since they were expanded. So what I think that the short answer there, what I will probably repeat throughout this testimony today, is that, quite frankly, this is something that, and we've hit on this before, is that this is a federal program in need of a federal solution. And the federal government's getting to that with lawsuits working their way through, with that agency action that's in question, with a case that was before the Supreme Court in the last couple of weeks. So the short of this is that it's a federal program run amok that needs a federal solution. And the genesis of the problem, the reason that the program has kind of gotten to where it is problematic and having us meet again, is that those contract pharmacies. So let's go to the next slide. Here, I just kind of want to highlight, again, this is I think this has been talked about enough over the last day and a half, but again, where these contract pharmacies fit into the program. Contracting with a covered entity to provide those prescription drugs to 340B eligible patients. The problem is we've talked about a lot of the oversight with the covered entities. We've talked about ways in which those funds are used, but none of that exists with the contract pharmacies. We can talk about charity care that the hospitals are providing. Those same things aren't necessarily being done by a contract pharmacy, and there's no oversight of the ways in which the contract pharmacies might be using the money that they are making through that program. Because, make no mistake, contract pharmacies are making a significant amount of money through this program. Let's go to the next slide. And this highlights, I think, just gives you concrete information about what that growth looks like. So I think, Representative Landwehr, you were talking last time about who the original entities were and kind of where they are today, who they are today. This highlights the growth in the program. While there are more covered entities and these child sites that were discussed earlier on, the biggest growth in the program is around those contract pharmacies, going from, I think it was 1,700 in 2010 to around 31,000 this year. That explosion is not something that is running to provide, it has any kind of real oversight. Again, it's an agency creation that has been poorly defined and is being litigated in numerous lawsuits. That is something that is running to money, and there's, again, no oversight for where that money is actually going. So I know a lot of the pharmacies that we've heard from so far have been, talking about the rural community and the small pharmacies, and I think it's all well and good to have that conversation, but we need to think about who these pharmacies are. And let's go to the next slide. And this goes to, when we're talking about 340B, let's not talk about the one-off. Let's talk about what the program is as it exists today and who these entities are and who these pharmacies are. The bulk of the program is going to be made up, or the bulk of the contract pharmacies are Walgreens, CVS, Walmart, Rite Aid, Kroger, and Albertsons. That's 70% of your contract pharmacies in this program, of those 31,000 contract pharmacies. So while there is a discussion about those contract pharmacies in rural areas, that's not the majority of the experience with a 340B program in the contract pharmacy space. It is, again, your CVS's, your Walgreens, your Walmarts, Rite Aids, those big pharmacy chains. So that's where the question has to come in. What's the oversight of this money? Because the substantial profits that are generated in the 340B program, we can talk about what covered entities do. They might provide some kind of a report that talks about what kind of charity care they're providing or what kind of programs they have for discounts. But that doesn't exist at the contract pharmacy. And they are making money through an agreement with the hospital to be a contract pharmacy. So again, there is not that oversight that exists with the hospitals. I think that's where, again, any legislation that aims to mandate that windfall continue to those pharmacies without any kind of oversight, I think is misguided and will, again, goes against misses what the federal government is going to be doing in this space down the road, whether it's legislatively, regulatory, or in the judicial branch, or all three at some point, to clarify where contract pharmacies really are supposed to fit within the context of the 340B program, because that question has never really been answered. The market has simply blown up in this space over the last 11 years and has generated substantial money and in the contract pharmacy space without any real oversight of what that money is doing or where it's going. And the last time, there's one piece that I want to, it was brought up last time. I think it was Mr. Von Osen who was speaking about the 340B program as a tax relief measure. It's a tax relief measure in that there is no tax levied on people via traditional means, not called a tax. But this is funded by taxpayers, whether they are businesses or insured members holding an insurance card, going to their pharmacy and picking up a drug. When they pay for that prescription, their insurance plan and their copay is going to fund the 340B program. So all those dollars that the hospitals or the covered entities are using that's going back to the contract pharmacy, that money is a tax by a different name. It is coming through the copay and the plan responsibility for that drug. So I think talking about it in a tax relief measure it misses how the program is being funded. It is subsidized by Kansans and employers in Kansas without any real say in how their money is being spent. So how it's being spent is kind of beside the point is, do they get a say in whether or not that money should be going to it? And the answer is right now, they do not. So the other point, I think this is one that I just want to reiterate what I started with, and that is around what we're looking for in this space is the ability to kind of have that parity, manage the way the Medicaid program does. Because the money that's going to be lost, we talked about rebates, and I don't want to belabor the point on rebates, but I think the Medicaid program is funded on rebates. Similarly, commercial plans use rebates to drive down the cost of delivering a healthcare benefit. So I want to make sure that we don't miss that, and we, again, stay with where the money's going, who it's being spent by, and who's funding these things, and who's funding this program, I should say. So, we'll end, again, I think that the tax piece, I want to hit that one more time, just saying it's tax relief measure is not something that is fair to say it's a tax by a different name. So I'm going to end. I want to keep it short. I know I had more information up here, but again, I don't want to repeat what you guys have heard about how the program works. I just wanted to reiterate the way in which we want to be able to manage the program, the way in which where an answer should come, and that's from the federal government because that's where it's happening right now via 7 different lawsuits, agency action, and proposed legislation at the federal level. And really, that's it. I want to open it up to questions that you might have for me since I was absent last time, and now I'm here for 2 sets of questions.
Thank you. Representative Carpenter.
Thank you, Madam Chair. I've got a notebook up in my office about a foot thick of all the information that we've got from this stuff, but I'm just kind of a simple guy. I'm trying to understand what's the difference between a contract pharmacy and a PBM?
So the pharmacy providing the prescription drug to a patient.
And where do they get their pharmaceuticals?
They would buy them from the manufacturer. And then so as far as via the 340B program, then they would be reimbursed or replenished that drug by the covered entity.
So how does a PBM fit in this?
We have a contract with the pharmacy to pay for that drug.
Okay.
And so let's say a patient goes and picks up their drug from that pharmacy. They've got insurance. It's going to pay through their health insurance plan administered by a PBM the same way any other claim does. So the patient is none the wiser, right? So I think that's where it's an example is actually worthwhile of, let's say a member goes to the pharmacy and they've got a high deductible health plan. So let's say, I'm just making up numbers here, but let's say they've got a $15,000 deductible and they have a drug that's prescribed by a 340B entity, they're a 340B eligible patient. They go to their pharmacy, that drug costs $500. That's the negotiated rate, or the contract rate between the pharmacy and the PBM. Patient goes there, they haven't met their deductible, they're paying $500 out of pocket. But the pharmacy will get that drug for pennies on the dollar. But there was no benefit to the patient. So when I talk about this being a tax, it's those people funding the 340B program, because that's where that money comes from. Because that money would flow back to the covered entity, and then a certain portion of that would stay as profit to that pharmacy.
But you have no control over that price?
Over the 340B price?
Right.
Correct.
The contract pharmacy. You're just the middleman. You make no money off of that or anything like that?
It would pay the same as anything else. So we would reimburse the pharmacy based on the contract rate.
And there's no money in it for you?
For us, no. We don't, and Prime does not own any pharmacies, so there's no, we would not be involved in that part of it at all. We don't have a pharmacy.
So with that, now you've opened another can of worms. There are pharmacies that own PBMs, right?
Correct.
Okay. So that's a different deal. Can you speak to that?
Well, and that's why I can. I think that's why I said that our issue is with the contract pharmacy explosion. And you see that growth when, in some of those areas where it is PBM-owned pharmacy chains that are benefiting from that. So I think that's where there does need to be an answer as to where contract pharmacies are supposed to fit into this, where they're supposed to fit into the federal program.
Okay. Thank you, Madam Chair.
Senator Gossage.
Thank you, Madam Chair, and thank you for being here. So we had talked about the Medicaid rebates, and Medicaid rebates are negotiated pharmacy manufacturers are required, they are mandatory, that they have to give these rebates to the Medicaid program. And that's a direct relationship. Can you explain the rebates through the PBM?
As far as, I'm sorry, as
You were
far as
saying
what?
there's a correlation?
The correlation between how Medicaid, yeah, so the Medicaid rebates are used to, again, fund the Medicaid benefit, right? So yes, and they're a creation of law required, but they're required so that they're put in there as a fiscal measure to ensure that that portion of the law, the Medicaid program created by law, can actually operate. In the commercial space, while it's not mandatory, it is something that helps fund the benefit. That's the way prescription drugs are bought and funded in this country, is we have the rebate system to help drive down that cost. That's a tool that PBMs use to drive down the overall cost of care, because that means that when you're paying less for your prescription drugs, you're paying less for the overall healthcare benefit.
So you were mentioning that this patient who came in and it was a $500 a month drug would, because they're a high deductible plan, they don't have a tier 1, tier 2, 3, 4 copay system, so they're paying the $500 until which time they reach their deductible. Can you explain how the PBM is involved in the rebate system and how that is with the employer? I'm a health insurance agent, I get it, but I think there are a lot of people listening who don't.
Yeah, I mean, I guess as far as, I mean, the rebate would be on the, that would be as far as like the actual drug between what we negotiate that price to be with the manufacturer. So we would negotiate a rebate of, throughout the year of X amount of dollars it's going to pay at the, at the end of the year based on utilization of a certain drug. And that money comes back as a, a check at the end of the year to help lower that overall cost. So that's going to be where your net cost is. Okay, there's the negotiated rate of the drug that's going to be based on, so there's the list price. Let's say that's, let's say that's $1,000, able to negotiate a essentially per drug rebate of $400 or something like that. So the net cost ends up being $600. So that's where you're, again, lowering the cost of the drug itself to the actual health, who is actually paying for that drug.
So what you're saying is let's say that this individual who's going to pay the $500 is insured, and typically through a self-funded plan with an employer, which would be like the state of Kansas employees who have a self-funded plan. And the purpose of the PBM is to rebate that from the $1,000 that it would have been from the pharmacy, the manufacturer, to give a rebate back to the employer of the $400 or $500, in which case that has dropped the price down to $500 for the person going to pick up the prescription. Is that what I'm hearing you say?
It's only the cost for the plan. Yeah, so the drug has that negotiated rate. Mm-hmm. And the rebate itself is going to end up coming back. It's not really on a per drug kind of. Mm-hmm. So I think that's the mistake. There's the negotiated rate. The rebate itself is going to come back as kind of a holistic check at the end of the year. That is a totality throughout the year. So as far as the actual individual right there, that's more, they're going to pay the negotiated rate. So the rebate's more of the going back to fund the actual plan and drive down that overall cost for the benefit itself.
So you can understand why there are folks who are thinking that the PBM that was said earlier today is now profiting because they don't want to, quote, reimburse at the same rate you would. So you're saying we are reimbursing the $500 back to the farm, which was the contract that was negotiated with the pharmacy. We're reimbursing back the $500. What we're not reimbursing back, or knowing that they're a 340B entity, pharmacy, contract pharmacy, they will have actually paid, because of the 340B program, they would have gotten all these discounts from the actual pharmacy manufacturer. And so even though they got this drug at a discount, making this up, $50 is what they paid for the drug, they are charging the person coming to fill the drug $500, and they want you to reimburse the $500 that they got, that they charged the individual. Is that what I'm hearing you say?
Right.
Okay, and so what you're saying is we're reimbursing this $500, we are not going to reimburse the $500 because they're not actually having to pay $500.
Correct.
So you want to reimburse the $50?
Yeah, well, really, end of the day, we're doing what we do in any space, is looking for a way to drive down the cost of care. Mm-hmm. And this is identified a way in what, identifying a space, the 340B program, where they're procuring drugs at a significantly reduced rate. So that's an opportunity to lower the cost of care.
And how is it lowering the cost of the care to the person who went to the pharmacy and got their drug and it was $500?
But that's what we're saying, is trying to, if we wanted to pay them, if that would be reducing the reimbursement. So any of the legislation that we're looking at is going to be talking about paying them, making sure that drug stays at that $500 and not being able to negotiate a rate that says, it's a $200 reimbursement if it's 340B because you're buying that drug at $150.
Thank you. Thank you, Madam Chair.
And just to be sure, you're talking about Medicaid, right, with the rebates?
No. There are rebates through a pharmaceutical benefit
Okay.
manager to the
Just- okay.
employer.
I just wanted to make sure that.
We're talking
that
two
was-
different
That
kinds
was
of
clear
rebates.
that it was, that with Medicaid, they're not allowed to take the 340B discount plus the
Correct.
rebates. Okay. Representative Wolfmore.
Thank you, Madam Chair. Thank you for appearing here today. Can your industry, not just your company, share your contracts with 340B and non-340B entities? Because it seems like that would be a way to get at what's really going on.
I can't say that, I can't speak to whether or not any individual companies besides ours, could share those contracts. That's more of a legal question as to whether or not we could. And I think the what's going on, like I said, I think a lot of it comes down to the contract pharmacy issue. I don't think our dispute, or I guess the issue, and like I said at the beginning, the issue isn't necessarily with the covered entity space. It's not, we can't decide whether or not the federal program is right or wrong. We're not going to question the policy there. It's about the contract pharmacy space. So I think the covered entity question is separate from the issue with contract pharmacies. And as far as your specific question about
Yes, my
the
specific
contracts,
question.
I can't say whether or not we would want to hand those contracts over. My guess is it's probably a no.
Because we're talking about transparency, and that would really be able to get at the information, whether what is going on is really going on. And then, I had another question. So you said it's a way to lower cost of care, and you talked about the tax, but actually, if the 340B program, the discriminatory practices continue, what's going to happen is, for example, our safety net clinics will lose a big portion of the revenue. That's going to come right back to face us here in the Kansas legislature, and we're going to have to fill in that gap. And so the safety net clinics use that 340B money to provide additional services. So that's how it lowers the cost of care.
And I guess I would push back with the question as to how the contract pharmacies provide that additional care that you're talking about. Because we're talking about the FQHCs or those critical access hospitals is one thing, but talking about where do the contract pharmacies fit into that and what kind of care do they provide that's additional?
Madam Chair, do insurance companies own PBMs in some cases?
Yes.
Okay. Thank you very much. Thank you, Madam Chair.
Representative Landwehr.
Thank you, Madam Chair. So, because I think what we've seen here today is that Medicaid is taking care of the issue of double dipping, but we may not have those same guardrails with our PBMs. Would that be accurate in our pharmacies?
As in the commercial space, like outside of Medicaid? Yeah. I think that's where you end up hearing more noise around this now, is that attempts to get some of those similar guardrails in place have been pushed back on, and that's why, again, there's more noise around it now.
Okay, and I understand the issue of perhaps not sharing what the contract is, because we do know that with our PBMs, it's different contracts with different entities, especially when you get it out in our rural communities, it is, or when you're dealing with ERISA health plans, it's a different deal as well. But there's nothing that would prevent, from what I have discovered, that would prevent our hospitals, for example, to give us what their the total is that they're receiving. It doesn't then tell us what their price is, but it would tell us that, yeah, we're receiving $100 million on this from this program.
Right.
Okay, thank you.
Senator Erickson.
Thank you, Madam Chair, and thank you for being here. Quick question to follow up on Senator Gossage and Representative Wolfmore's line of questioning. You said that the purpose was to lower the cost of care, and I've heard implications for the cost for covered entities. My question again to you, and my concern, is the cost of care for the patient. Is there evidence that it's lowering the cost of care for the patient? Are the savings being passed on to the people that it's supposed to affect and the purpose of the program?
I think that's a question for the covered entities. I can't say how they are or are not spending the money that they receive through this program. And I can say, and like I said, there might be reports that they provide, but those things don't exist in the contract pharmacy space. So as far as whether or not they're providing any kind of additional care with the profits that they generate through the 340B program, I can't say. And there hasn't been any oversight of that.
Thank you, Madam Chair. Just a quick follow-up. As a layperson who admittedly is not immersed in this space, okay? This, to me, kind of epitomizes what's wrong with, quote, government programs. We've created a program with well-intentioned, but everyone's wants their piece of the pie. I want to know how this helps the patient. I'm hoping at the end of the day, when we talk about committee recommendations, that's our focus. But just seems to me sitting here listening, there's a lot of people making a lot of money, and I want to know how it affects the people it was intended and created for. So I appreciate you being here today. Thank you, Madam Chair.
Can I respond to that real quick? Because I think that's right. I think to focus on how that affects the patient, a lot of that comes down to how much they're paying for their benefits or paying for prescription drugs. And I think we would want to say that this is another tool that can be used to lower the cost of healthcare for health plans, for consumers, for poor people, insured and uninsured alike, as far as where these savings are going and how they're being used. I think mandating as a matter of state law that this windfall continue kind of unchecked, that would not do anything for that patient.
I agree that it can and it should. As someone who obviously, an end user who goes and refills prescriptions, I can tell you, I have not seen my costs, nor anyone I talk to, their prescription costs going down. That's my concern. Why isn't it, if that's, the intent of this? So thank you, Madam Chair.
Senator Hildebrand.
Thank you, Madam Chair, and thank you, Alex, for being here. I have a couple questions for you. The first one, you mentioned covered entity and contract pharmacy, and I believe our conferee earlier just used the term covered entity. So would a contract pharmacy still be a covered entity, or is that a different definition and handled differently?
So I'm always smiling because your question is exactly why we have this issue, right? The fact is contract pharmacies and covered entities are different. So the covered entity is what the 340B program was designed for, was for the covered entity to procure drugs at a discounted price from manufacturers. Contract pharmacies were a creation of the agency of HRSA to allow them to, so with hospitals that are covered entities that didn't have a pharmacy, to then expand, be a part of the 340B program and to provide drugs via the 340B program in those spaces. So as far as how they should be handled, there was the original creation of them and then the expansion of them, and there's never been any real definition or thought about exactly where they fit into the program. That's why there are 7 lawsuits at the federal level trying to answer your very question right now.
Thank you. And one of my other questions, we've heard the term double dipping quite often, and can you explain, just kind of walk through a scenario how double dipping affects, like how a PBM, I understand, I think Sarah Furtag gave us a good example how Medicaid, how it's not double dipping. But can you give me a good example and a good walkthrough on how double dipping works on the PBM side?
Yeah, and I appreciate your question. I think probably should have hit on that earlier, but I think the double dipping thing is it's a similar fashion where our contracts with our rebate contracts with manufacturers would say that those are not eligible for a 340B discount. So if that drug claim ran through 340B or the pharmacy purchased through 340B, that should not be eligible for a rebate. But if we can't identify it as such, and then, so let's say person goes, gets their drug, ends up being 340B, but it's not identified by the pharmacy as such, that claim is part of our rebate file that we send to the manufacturer at the end of the year, and they pay a rebate on that drug. Well, they go back and audit all those claims and identify, X number of claims that were actually run through 340B. So they claw back those dollars that were paid, they paid rebates on, and since they were ineligible. So it's the same thing as in the Medicaid space. And so what happens is, and I actually saw this in one of our states, one of our clients had this happen where manufacturer goes through, audits that entire year's worth of claims, says rebates were inappropriately paid on, this, I can't remember what the exact number of claims was, but it amounted to $500,000 worth of rebate dollars that they then clawed back. And where that money comes in, and it's a small state where $500,000 is a lot of money, and that goes directly back into raising premiums for the next year.
And then my last question is, we're talking about rebates. So do pharmacies get a rebate? Do the PBMs get the rebate? Do the insurance carriers get the rebate? Or do the individuals that have the insurance policy get the rebate? There's 4 different possibilities, and we've heard rebate mentioned several times, but it's still a little confusing on where that rebate actually goes.
Yes. Well, there are various rebates. So there are pharmacy rebates as far as how they purchase drugs outside of the 340B program, but that's a different kind of rebate. But the rebates I think we're talking about here, those we pass through all rebate dollars. So we're a pass-through pharmacy benefit manager. So those rebate dollars go to the health plan to administer the benefit and drive down the cost of that benefit. Exactly how that check is used on the health plan side, I can't speak for the health plan, but we pass through all those rebate dollars to our clients.
So that brings up a follow-up question. And in the world of commercial insurance, there's fully insured and then there's self-insured. So if it's a self-insured entity, does that go back then to the company that is administering, that the person is working for, to offset their costs for future costs for their insurance? And if it is a fully insured plan, does it go to the insurance company?
So fully insured, it's going to go straight back to we pass through all to the insurance company, our clients, I should say. Whether or not, when they actually ended up owning the contract with the self-insured plans, so whether or not they pass that through to the self-insured plan is going to be a matter of contract between that health insurer as a benefit administrator and the self-insured plan itself. So it's going to vary plan to plan. I'll just say that for us, that we know that we pass through all the 100%.
Senator Pittman.
Thank you, and thank you for being here. Really appreciate you making the trip. So kind of going off the senator's last question, you pass on those rebates onto the health plan, and then the health plan, much like the hospitals, doesn't really need to report out how they use those things for the benefit of their constituents, right? Their stakeholders.
You'd have to have somebody from the health plans to answer that question.
So, okay, so basically, like the hospitals, you don't necessarily provide that transparency out to us, though, right? From your PBM point of view, right?
To the state? No.
And do you give a lot of transparency to what your rebates are and how those are being used to the state?
We're transparent to our clients. So we contract with our clients. Part of our contracts with them, those health plans, would be what kind of transparency they want as far as audit rights, what kind of information they want in reports. And so we're transparent to the extent required by the contract with the client. And whether that client's the state or a private health plan.
Right. So from a commercial standpoint, you've got some transparency to your clients about how you're operating, et cetera. I got it. That makes sense. So your big issue, though, isn't necessarily with 340B or how the hospitals or anything around that. You really are focused on these contract pharmacies, right? It's kind of, you're solely focused. You feel as though your business plan is good. You've inserted yourself into this. You feel like even if there was no 340B program, would you have any money coming into the PBM at all?
We don't generate money through the 340B program.
Nothing at all? You don't profit at all from
I can't say nothing. I don't know specifically whether it's nothing at all, but since we're not a pharmacy, we don't own any pharmacies, we're not going to generate any profit from the 340B program. The 340B program is going to generate profit for pharmacy and covered entity.
So your profit, though, it comes from somewhere. Obviously, commercial entity, you're not a Medicaid, you're not a government entity, right?
Right.
Yeah, so you get some profit from somewhere. It's not directly from the funds from 340B, but you do get it from negotiated rates, I guess you could say. You're providing your clients a service at some dollar amount, undisclosed, and for that client dollar amount that you're charging your health plan, you negotiate rates and limit the, I guess you could say, exposure for your clients?
Right. So again, all of those things are just ways in which we're trying to negotiate a lower cost of administering that prescription drug benefit. So I'd say where our role is just that we want to stretch that premium dollar as far as it can possibly go, right? To make sure that you get the most bang for your buck with your prescription drug benefit.
So your health plan clients, whoever's got health care through that particular program, you're trying to stretch their buck because that's who you're working for, right?
Yep.
And that's fair enough, right? So you're not necessarily working on behalf of, say, the indigent folks out here in Kansas right now. You're working on behalf of your clients who are the healthcare plans.
Our clients and their members, yes.
Yeah.
And as far, I mean, because indigent, I think, is a different question, right? That's going to be a state question issue with Medicaid and then uninsured. And I think those are separate discussions. Like we exist fully in the insurance world.
Right.
And so anything.
Make sure we understand you're working for the healthcare companies, and your main beef right now from your testimony is with the way that you're doing your services for your health plans versus the way the contract pharmacies work. That's solely it. It's not necessarily, you're not out advocating, you mentioned taxes, which is a pretty big word to go into, given that a lot of your benefits, come from discounts. So it seems as though, would you say that if we looked at Kansas and looked at your services you provide your health plan, would you say you're expanding the access to some of these drug benefits to our constituents?
I can't, that's going to be purely a benefit design question as far as what benefit the plan wants specifically. So if it's a self-insured plan, what kind of benefit they want to provide, full insured plan, which product you're offering. We administer the benefit that's designed by the plan.
So if the healthcare plan is doing something, would you say that, for example, do you limit the number of places I can actually pick up my prescriptions from if I'm part of the health plan of one of your clients?
The health plan might choose a plan with a more limited network of pharmacies, yes.
And that's that's kind of how the PBMs work, right? I mean, they kind of limit the number of options in order to cut costs and that kind of thing, right?
Yeah, and at its core, it's managed care, right? Like if you can narrow that network, there's cost savings to be had there because you can negotiate a lower rate in exchange for higher volume at certain pharmacies.
And do some of these, I'm sorry, Madam Chair, am I okay? Just one more question?
One more.
Okay, I'm sorry, I get on a track and I just start going. I'm sorry, and I appreciate you answering the question, I really do. If I'm taking, if the good senator mentioned, we have a lot of stakeholders out here who are profiting off of a well-intended program. If we were to take the PBMs out of the picture, we'd have a little bit more money, in my opinion, for those hospitals to stretch further. I think your argument against that might be, but we're going to drive costs out of the whole system, right? Is that kind of where your position is? Because I feel like there's a middleman that's been introduced and it's profiting off of, for the health plans, this discount. That means that the whole pie just got smaller, and where that pie needs to go to our Kansas hospitals and then subsequently to our constituents. I just don't understand how you can take some of that money out and say that there's a bigger pie. I just don't get it.
So I do want to, so first, and I should have introduced this earlier, if there are other questions for PBMs, we do have Melody Schrader and Jonathan Buxton from our trade organization that can also help answer some of those questions at some point. But I think overall, as far as how we provide value to the system, I think the proof is in the pudding of the fact that nobody's required to use a pharmacy benefit manager. And yet, time and time again, people use a pharmacy benefit manager to administer their prescription drug benefit. If we didn't provide value, we wouldn't have existed. We wouldn't have proliferated over the last 30, 40 years. So I think that's the simplistic way of looking at it. And if you just want to look generally, economies of scale drive lower costs. So if you want to go buy something and you buy a single unit of that product, is it going to be more expensive than if you buy 10,000 of that unit? And the answer is yes. That's where that value comes, that economy of scale. And so that's what we do. We don't just negotiate on behalf of, the 20 members that are under one specific plan. We negotiate those costs for the 100 million members that are under that umbrella that we provide services for.
That was your one more, so you're I can see you're biting your lip. Alex, are you staying the rest of the day?
Yes, I am.
We have a conferee that needs to leave, and then we're going to need to break from lunch, or I will have hangry committee members. So I'm wondering if we could pause your testimony now and come back to it
Absolutely.
this afternoon.
Yeah. I hope I don't run into any travel issues getting up and down the stairs of the state capitol, but I will do my best.
Well, they're awfully clean today, so be careful. Okay. And those of you who have questions, I am keeping my notation of where we're at in that list. Representative Miller.
I was going to ask him if he was going to be around this afternoon because I wanted to ask him questions specifically after we hear the 1:30 testimony. Could you make a note of that?
Yeah, we are going to stick to that 1:30 testimony because those
my
are,
question for him will be relative to what I think we're going to hear from that testimony, so I'd rather wait until after they've testified before I ask him questions.
we will have to. So, yes. So at this point, we are going to ask Daniel Kreitz to come to the podium, and he is the CCO of the Community Health Center of Southeast Kansas. And I'll tell you that the hospitals that we had come speak to us our last meeting, we had, I think the discussion was we were trying to get a large hospital and a small hospital. And so this time, but the smaller hospital was actually part of a network. So this time I asked that we find a couple of conferees from a very rural area that are just a small freestanding facility. And so Daniel, we have you up first, and thank you for, I'm sorry we're running late, but
you're fine.
Thanks for being here.
Yes, thank you. Thank you, Madam Chair, Madam Vice Chair, and the members of this committee. My name is Daniel Kreitz. I am Chief Compliance Officer for Community Health Center Southeast Kansas. In that role, I have the privilege of implementing and overseeing our 340B program. At Community Health Center Southeast Kansas, our values originate with one statement: doing all the good that we can for all the people that we can in all the ways that we can for as long as we can. At Community Health, we live by this statement, which originated 100 years ago when a sister of St. Joseph brought health care to the poorest region of Kansas, Southeast Kansas. This sister, Mother Sheridan, built a hospital, Mount Carmel Regional Medical Center, literally yards away from our North Pittsburgh campus, to provide health care to all, regardless of ability to pay. She frequently told her staff, who are providing care to the minors and immigrants of the region, who continue to live in the region today, that they should do all the good that they can in all the ways that they can to help the regions, improve the region's health care and help it prosper. While healthcare and delivery has improved the past 100 years, Southeast Kansas continues to be collectively the poorest and least healthy region of the state. Today, CHC continues Mother Sheridan's views and values through our mission. The first slide will tell you that we're a federally qualified health center, a Kansas not-for-profit corporation, and a 501c3. We are per federal law, we have to be minimum of 51% patient-owned and operated. Our board is about 70%. The federally qualified designation came about in 1991, but has its origins back to the War on Poverty with President Johnson. There are approximately 1,400 health centers in the country today, and CHC is allowed to participate in the 340B program because of our partial funding under Section 330 of the Public Health Service Act. CHC has approximately 39 sites in Kansas and Oklahoma that are open 1,141 hours a week. We provide all of our services 60 plus, regardless of ability to pay, with no collection agency. which means that if you cannot pay for services, we will not seek those monies from you through any formal collection process. We have approximately 725 employees, and we provide care for about 70,000 people annually. If you know the population of Southeast Kansas, you'd know that's about 45 to 47% of the population. Some unique things about community health and how we use our resources appropriately is we employ the only 2 pediatric dentists in rural Kansas. We maintain the unused medications repository for the state of Kansas. We're the only FQHC written in state law. We have one of the largest school health presence in the country, with over 50 school districts and 75 FTEs in schools providing care for Kansas kids and Oklahoma kids. This includes medical, dental, and behavioral health care. At all times, we have about 100 students rotating through our clinics. We're very big on education because no one's coming to save us. We have to train our own staff so that we can continue to survive. And 2 things that have happened more recently that we're incredibly proud of is that we have an accredited family practice residency program with KU that'll start in August of 22, and we have a pediatric dental residency program with NYU that'll start in August of 22. The next slide tells you exactly where our patients are from. Per federal law, we're required to submit data annually, both financial and population-based data. This data gets published through the Uniform Data System, also known as UDS, and tells us where a majority of our patients come from. The dark spots inform you of where we have what's called a hotspot, which means that if we wanted a brick and mortar clinic there, we can submit for federal approval for that. We have to get approval to have brick and mortar clinics. Those hotspots on that screen show you Pittsburgh, Fort Scott, Lynn County, Iola, Chanute, Coffeyville, Parsons, Cherokee County, and Miami, Oklahoma. That also includes 2 spots in Missouri, Nevada, and Carl Junction. Again, those patients are traveling to us to seek care because it's highly affordable and provided regardless of ability to pay. So why are these services through an FQHC, services like 340B, so important in Southeast Kansas? All 9 counties rank in the bottom 25 counties in Kansas in terms of health outcomes and health factors. State of Kansas, on average, ranks 33rd or 34th in terms of the healthiest states in the country. If you were to remove Southeast Kansas, we would be the 9th or 10th healthiest state in the country. The next 2 slides show you health outcomes and health factors. You do not want to be a dark color. Health outcomes, you can see 8 of the 9 counties in Southeast Kansas rank in the bottom. These are length of life and quality of life. Next slide is health factors. As you can see, all the counties of Southeast Kansas rank in the bottom. This is healthy behaviors, access to clinical care, and social economic factors. I'm going to spend the remainder of my testimony talking about one specific county, Cherokee County. Cherokee County ranks 102 out of 104 in terms of health outcomes and 96 out of 104 in terms of health factors. Growing up in Cherokee County means you're 90% more likely than other Kansans, if you're to grow up in other counties, to be born to a teen mother, to live the entirety of your childhood in poverty, live your entirety of your childhood food insecure, and as an adult, become obese and suffer a premature death. What CHC does in Cherokee County is presented to you on the next, starts being presented to you on the next slide. These numbers are accurate as of Tuesday. We provide care to, this year, we've provided care to 7,390 out of the 19,362 residents of Cherokee County. It's 38%. Of those patients, 63% are on Medicare, Medicaid, or uninsured. That means that we take care of approximately 68% of the county residents who live below 100% of the federal poverty level. The 340B program through CHC helps address these realities in Southeast Kansas. We employ 50 staff who reside in the county. We have 2 clinics in Baxter and Columbus. We have school-based services in Baxter Springs and soon Galena and Columbus through grants through KDHE, because KDHE recognized the need for school-based self-services in Cherokee County. And we have the only in-house 340B pharmacy, Apothecary Columbus, within the county. Again, we provide all services, regardless of which site you go to, regardless of ability to pay, and on a sliding fee. That means that if you need a medical service and you present to our Columbus clinic, you present with a fever, you can get these services, which would include a medical visit with a provider, a lab, and an x-ray for a total of $15. Within this county, we also have 3 contract pharmacies and 1 in-house pharmacy, as previously mentioned. A real-life example from last week about the affordability and need for 340B pharmacy in this county. Patient of record who reported at less than 100% of the federal poverty level had asthma, needed Symbicort, and got it for a cost of $1 per inhaler. If there was no 340B pharmacy in this county, which means if Community Health Center didn't have contract pharmacies or didn't have our in-house pharmacy, that would cost $400 per inhaler. What I can tell you is that when we provide prescriptions, we do it at the most affordable rate possible. We will provide prescriptions over 40,000 prescriptions at the same affordability rate in Cherokee County this year. We'll provide almost 400,000 scripts system-wide at the same affordable rate in the most medically needed communities in this state. Now, there's been a lot of conversation about how contract pharmacies use this income, if there is some. I will tell you how Community Health Center Southeast Kansas uses this income. We employ family resource specialists who provide support for pregnant women, children, and families. We employ diabetic health coaches, help address diabetic needs of patients. We employ community health workers who often provide transportation for people that lack it, nursing coordinators, and referral specialists, all of which are vitally important to the prosperity of this county, and of which CHCSEK has limited or no reimbursement except for using 340B income to employ these people. That is my testimony. I welcome any questions.
Thank you, Daniel. Senator Hildebrand, this might all sound a little familiar for you, doesn't it?
Thank you, Madam Chair. I really got really depressed when he said my age 70 was my life expectancy, so you guys don't have to put up with me very much longer, apparently. So, Daniel, thank you for your testimony. I am a product of Cherokee County. Was raised there, so I wasn't born there, but I was raised there, so I am one of those statistics. My question, though, is community health clinic, you say you're designated as a contract pharmacist, not a covered entity?
No, we are a covered entity. We are a federally qualified health center funded under Section 330 of the Public Health Service Act, which means we are a covered entity. We can contract in rural Kansas with contract pharmacies to provide the medications at the same affordable rate. but we can also do it through our own pharmacies. We have 6 in-house pharmacies.
So your in-house pharmacies are considered a covered entity.
They would be a part of the covered entity, that's correct.
So, but if someone goes outside to one of the local drugstores in Baxter Springs or Galena that is not yours, that would be a contract pharmacy.
Yes, yes. Yep, any one of the handful of independent pharmacies in the county.
So do you guys then get a rebate or funds every time someone goes to a contract pharmacy? Is that why it's important that you keep a contract pharmacy, or how does that work?
It depends on the insurance status of the patient. Frequently, if it's underinsured or an uninsured patient, we are giving away the prescriptions at the cost we're given it. And in a county that's we serve between 63 and 68% of the most medically indigent, we're not, I guess what you'd say, making money off the program. We're giving away the scripts to help improve the healthcare.
Right, I understand that part. I'm just trying to figure out the contract pharmacy piece, where it falls into the covered entity piece for you guys. So if I come to you and you give me a prescription, but I don't get it filled from you, I go to a contract pharmacy. How does that affect what you guys get paid by going to the pharmacy?
Yeah, in the end, we end up paying the contract pharmacy a contracted fill rate where they it depends on the contract, but they're supposed to cover their overhead is what is supposed to happen. Now, whether we end up just eating that cost is completely dependent on if the patient has any form of insurance. If the patient doesn't have insurance, I'm eating the fill rate, and that's just how it works. But we have a virtual inventory system, which you heard alluded to, which was the movement years ago to get away, which helps with the informatics pieces. And I would say, not knowing exactly the context of all the conversations you've heard on this, we are audited year-round. HRSA audits us 12 months a year. I know it's supposed to end at some period of time, but we get questions all the time. And we get audited by insurance companies. Our auditing processes never stop. And I'm asked questions at least a few times a year about our prescriptions that we give away at both in-house and contract pharmacies. I'm asked about the eligible patient issue, the 3-prong issue you heard earlier. I'm asked about where the money goes. We're constantly, from a covered entity perspective, we are constantly asked questions.
Okay, so just so to clarify, so if I went to Community Health Clinic in Baxter,
okay,
you gave me a prescription, I go to the local drugstore, and if I don't have any insurance, then the Community Health Clinic then pays the pharmacy for filling that.
We pay the pharmacy no matter what, if you have insurance or not.
So you pay it no matter what. Okay, thank you. That's why I was trying to draw lines to you.
Senator Gossage.
Thank you, Madam Chair. Thank you so much for being here. I feel like we're hearing different things, so I want to clarify. So we heard from the PBN testimony that their beef is with the contract pharmacy. I read from the individual who I guess is your counterpart in Northeast Kansas about how they went from 3 to 8 contract pharmacies, and then something happened in August of 2020 where it was frowned upon to have contract pharmacies, so they no longer offer the 340B discount price to covered entities with contract pharmacies. But yet you're saying you still have contract pharmacies. I'm trying to understand what happened in August of 2020.
Well, in August of 2020, I would say just the summer of 2020 to be perfectly transparent. We were notified by certain insurance companies, PBMs and others, that they weren't going to cover the cost of certain drugs. They're just, that was the nature of it. So that has certainly affected some availability of medications at those contract pharmacies. So what I would tell you is we continue to have contract pharmacies because we don't have in-house pharmacies at all of our clinics. It's not possible. So when we're talking about it, you know, I think a lot of times the covered entity gets caught in the middle of an argument that doesn't necessarily involve the covered entity. And traditionally, I think that's at the heart of this because we're providing everything we do regardless of ability to pay. And like I said, we're very transparent with our federal governing body about what we have to do, both from an operational and a financial perspective. We have it's just very long and convoluted. So, but we have a very long audit process.
So to be clear then, you do work with contracted pharmacies?
Yes.
And then, but there are some medications that some of them don't cover, or certain insurers or PBMs are not covering?
That's correct.
Okay. And then you mentioned by the way, I lived in Fort Scott and went to Fort Scott Community College, very familiar with that area down there. When you said we have very unhealthy people.
Yes.
And my fellow senator aside, if there are unhealthy folks, and it sounds like primarily unhealthy folks down there, then have we seen a difference since the 340B program was instituted in your area? Are people becoming healthier? Or have we seen a difference?
Well, Community Health Center originated as the thought of my CEO in 2003. So we've originated since the creation of the 340B program. And I honestly believe, and the data would support it, that our existence has helped improve the health of the area.
And you can believe that. Do we have any data?
Well, you have to submit, we have to submit data annually about what we do. So I guess Cherokee County is another great example. So Cherokee County has a sole critical access hospital based in Columbus. Cherokee County has one or two private physician groups. It has an orthopedic group that's on the state line on the way to Joplin. There really is no primary care presence within the county without us. Mm-hmm. We employ the only family practice physician in the county. So, you know, I would be able to tell you through, it would take digging, but you could see through uniform data system reports what we have done and what effect we've had on the county through the services we've provided, which would include pharmaceuticals.
All right, and thank you, because again, we often hear about government programs and it's designed to try to help these entities, but then it seems like they never really do data to find, did it really help what it was supposed to help?
Yeah, I mean, we have to submit data every year that tells us we're making our communities better. That's the moral of the story.
And finally, we have heard this dispute about the contract pharmacies. Like you said, we get caught in the middle. Could you define for us two things? One, how is it that the contract pharmacy is compensated? And then how do you get compensated through the contract pharmacy? Because obviously that's how you get your money, right? The 34B program comes because of having the pharmacies.
Well, we fill more scripts in-house at our in-house pharmacies than we do at contract pharmacies. Okay. So I would lead with that. 75% of our scripts are filled in-house. Mm-hmm. So with that in mind, when I enter into a contract with a contract pharmacy on behalf of Community Health Center Southeast Kansas, the contract pharmacy is guaranteed a rate that's traditionally called a fill rate from us, regardless of insurance status of the patient, that pays them traditionally for their cost of their overhead. The pharmacist, the pharmacy system, the bricks and mortar. That's what it's intended to do. Now, if there's any insurance remuneration, it's technically, and this depends on the contract or the PBM or who's involved, that is technically, the vast majority of that is technically supposed to come back to the contract pharmacy, or the covered entity, to be used appropriately within the body of what we do, to employ family resource specialists, to employ diabetic health coaches, to employ referral specialists, all these things, provide transportation, these unreimbursable things. So I would tell you, traditionally, that's how it's supposed to function. Does it function that way all the time? No, because Community Health Center Southeast Kansas, or FQHCs, covered entities, get in the middle of a fight that doesn't involve really us. involves either the contract pharmacy, the middleman, the wholesaler, or the manufacturer. All I'm doing is doing the good that I'm supposed to do in the community.
Thank you very much. Thank you, Madam Chair.
Representative Miller.
Thank you, Madam Chair, and thank you, sir, for the work your entity does for Senator Hildebrand's constituents. What I got from your testimony is that the 340B program is important, if not vital, to the work you do.
Oh,
What I didn't get from your testimony is what is the problem we can address as legislators if there is a problem?
I think the legislation that you have proposed before you is a great idea.
I don't know what that is.
The House bills.
The ones that are listed on the agenda?
Yes.
Okay.
Yes, the House bills. I think they're great ideas. I think there's, maybe, being an attorney, I think there's a definition or two that could be helpful to be flushed out in there. Medical care corporation is not a common term used.
But you answered my question. We'll get to those.
Yep.
What problem are you afraid of us creating?
I don't know that I'm afraid of any problem that you could create.
Wow, you haven't been around.
We are built to be transparent. Federally qualified health centers are built to be transparent. We're built pursuant to our creation with the war on poverty to be patient-owned, patient-operated.
That's good. The chairwoman needs to move along. Thank you.
Yeah.
Thank you, Madam Chair.
Representative Carpenter.
Thank you, Madam Chair. I think there's not very often that I can speak for everybody at this table, but we appreciate your work on FQHCs are a vital part of our state health plans and our Medicaid folks and everything. So thank you for being here and thank you for what you do.
Thank you.
We're trying to do no damage here, as Representative Miller said. We don't want to, but a couple of things I need some clarification on. So your in-house pharmacy is not a contract pharmacy. You contract with other pharmacies and then you fill their prescriptions through your in-house pharmacy. Is that correct?
No, we have 6 in-house pharmacies that are associated with our TIN, our tax ID number. So those are physically located in our brick and mortar clinics. If it is a contract pharmacy, what happens is, let's use Lacine, for example. Lacine's a great example. So we took over operations of a clinic in Lacine from Olathe Health, who was no longer going to provide services to the region or to that specific community. That community is about 1,500 people. We have a medical clinic there that's staffed 7 to 7. But we have no in-house pharmacy option located in that town. So what ends up happening in that instance is if you get written a script, you visit there for you go in for a medical appointment, you need a script and you don't want to travel out of town, well, the pharmacy happens to be right across the street. The contract pharmacy does. It's a privately owned, small, 1 or 2 pharmacist operation. So what happens is then it's a virtual inventory process where we send over the script or you present to the contract pharmacy. They fill the script on our virtual inventory, our book of business. They take a fill fee. If you are uninsured or underinsured, we may or may not get paid anything for what you do, and we might eat the cost. Likely would eat the cost. If you are insured, we might get some form of insurance remuneration, which then we use to employ other people in the county to provide transportation to you or whatever.
Okay, so who provides the pharmacies to your in-house pharmacies?
Well, we can set up our own pharmacies.
But you buy from what, PBMs?
Yeah, we buy prescriptions from anybody, any wholesaler that could sell them to us. McKesson is one of the more prominent wholesalers. PBMs do get involved, just based off of what the insurance or non-insurance plan looks. But yeah.
Okay, and then, so your program, there are two different ways. One, you're reimbursed for the funds, and the other one, they refill your, whatever you've used on that 340B person, is that correct?
Correct.
So which one do you use?
Well, if you're in, sorry, can you repeat your question? I'm sorry.
Well, there's two methods for repayment for your 340B drug, money, and then also just a refill of that item.
Well, it's on our book of business, so it's always, we are issued invoices, or we issue invoices to contract pharmacies. It's always on our book of business. So it's never on their book of business. It's on our book of business.
Right, but are you get reimbursed the 340B price, or do you just get the medicine to replace that?
Well, given it's on our book of business, you do a true-up process. So if it's acquired, on our book of business, we're reallocating the pill via 340B pricing mechanism. Does that answer your question?
No, but I'm not sure I'm smart enough to figure it out, so thank you.
I apologize.
Representative Wolfmore.
Thank you very much. Thank you for your testimony today and the work you do. So can you explain to me two things? One is, this bill is about discriminatory practices, PBMs, and how it's affecting 340B programs in Kansas. So how do those practices affect you, maybe what really happens? And then the second question is, let's just say that practice continues and you're very limited in what 340B funds you have available. What really happens in a real world to a lot of your programs you have in Southeast Kansas?
Well, if discriminatory practices continue, it's less money to reinvest in the communities we serve, which means we get to do less things. I mean, it's pretty simple. And in Southeast Kansas,
Magnitude of that, or?
340B for any entity is a multi-million-dollar process. So, I mean, it's hard to quantify specifically based off of how much discrimination has happened now and will happen in the future without legislation like this. But if it continues, inevitably we can do less. A great example would be we're putting in CT services in Pittsburgh that'll go live in January. Well, and we're going to do it on a sliding fee. So, if that doesn't work out, how do you think we do that service? That is a six-figure piece of equipment. So, I guess my answer to your question would be less services are being provided every day in Southeast Kansas. And if we're not going to do them, and we don't have 340B as a part of our program, that means we do less too, which means the communities get less healthy.
And then could you talk a little bit about the discriminatory practices, what's really happening?
Well, yeah, I mean, my written testimony gave a great example of, there is vast differences based off of how contracts or guidance is being written by PBMs or insurance companies that talks about how you fill scripts based off of a 340B inventory or a retail inventory, and that directly affects the amount of money you can be reimbursed. And that affects the amount of money or the services we provide in communities.
Thank you, Madam Chair.
And was that a recent change?
All of these issues have really presented themselves in the last 2 years. The severity of it has happened during the last 2 years.
Representative Tarwater.
Thank you, Madam Chair. I had a few questions, but that last one, the discriminating practices, I want to follow up on. So when the discriminating action would be if you have a compilation of pills that were reimbursed or were 340B pills, but you also have other pills that you sell to other people you can't mix them up?
We have we maintain what's called dual inventories. So you have a 340, we can be a retail pharmacy and we can be a 340B pharmacy. So what happens often is that a contract or a guidance is provided that it says they just won't reimburse you. You can give the pill away, but we're not going to pay for the pill. So, on a 340B inventory.
If it is a 340B?
Yeah, my written testimony talks about that because the language is often written where it directly affects it, where if you can fill at a 340B rate, but you're either not going to be paid or you're going to be paid less. You can fill on a retail and
are you talking
something
about
different.
For, maybe I'm confused a little bit on the scripts. If you have a contracted pharmacy and you send them a customer, they're a 340B customer no matter what.
Yeah, if they meet the three-prong test, yes.
They came from you, they're filling it so they do.
Yep.
What if somebody walks in the pharmacy that's just an insured individual that did not come to you?
If they're at our in-house pharmacy, at a couple of our pharmacies, they can fill on our retail side because we maintain dual inventories. If they're at a contract pharmacy, they're not going to be a part of our program.
But you bought the drug for the same price.
They're not a part of the program because they don't meet the tiers.
That's not the question. The question is you bought the drug for the same $1. The inhaler example you used, you bought it for $1. You're going to sell it to the insurer guy for $400. But if it was someone without insurance, they get it for $1.
Well, yeah, that's 100% accurate. We are supposed to provide our pharmaceuticals on a tiered system, and we provide them on a tiered system, and that happens at Community Health Center Southeast Kansas. And if you can't pay for your prescriptions, we don't have a collection agency. We're just not going to get paid.
Could you sell that inhaler for more than $1 to somebody that had $50 in their pocket?
Are they insured? They uninsured? They partially insured?
Uninsured?
No.
You have to sell it to them for $1, or is that your policy?
We follow our sliding fee scale, which is per federal directive, relevant to all services. We follow if you're insured, we follow whatever good practices are, but we don't set our contracted rates. I think that's something that's getting lost. Community Health Center Southeast Kansas, we are a drop in the bucket. So we don't set contracted rates, and we get paid what we get paid. And that's just the truth.
Contracted rates from?
Insurance companies, PBMs, it doesn't matter.
Okay, so you contract for these rates, and what you're worried about is they're trying to negotiate with you because you're buying things for $1 and selling them for $400, and they're wanting to maybe pass some of that savings along to their customers on the ones that are insured.
We're passing the savings on to their customers through services we're providing in the communities.
Oh, so you're taking the discount from the customer and applying it where you'd like?
It's not where we like. We're per federal directive.
Where you need to.
Per federal directive, we're supposed to reapply it in the communities when we do it.
So when you say they're not covering it, they're wanting to reimburse at a lower rate?
Sure, yeah. Yeah, that's...
Okay. And then how many prescriptions would you say your organization writes for opioids?
I do not have that number.
Can you take a guess?
No.
Percentage?
No.
Any?
I honestly don't have the number in front of you. We do medical assisted treatment, so we commonly address the opioid epidemic. So we provide Medicaid assisted treatment in some of the communities that are most severely at issue with different drugs.
I know it's a big problem down there. That's why I'm asking them. So are they? They can come in and get opioids from you for free if they don't have insurance. Is that true?
Well, I guess I'm lost on it. we provide appropriate medical care to everybody. So if someone comes in with an opioid addiction, we're going to appropriately treat it. We're not going to give an opioid away.
Okay, thank you.
Senator Erickson.
Thank you, Madam Chair. Just very quickly, in your testimony, you mentioned that by January 2021, all insulin manufacturers were no longer offering the unrestricted 340B discounts. You also say lawsuits are pending related to pharmaceutical manufacturers no longer offering the 340B discount to contract pharmacies. Do manufacturers have to participate in the 340B program?
Yes.
They do. Okay. Thank you.
You said it would be a yes or no, and you were right. Okay, Senator Gossage.
I know I'm standing between us and lunch and everybody in this room, so very quick question. So we appreciate all of the things that you're doing for the community, that the organization is doing and trying to help folks. I guess what I'm trying to understand is we've not heard a dollar. So can you tell us how much it is that the Southeast Kansas Community Health Center receives from the 340B program?
A specific dollar amount?
Or
I don't
as
have
close as
a.
you can get it.
I don't have a specific dollar amount. I'm honestly trying to do the math in my head, off the top of my head. We have a budget of about 70 million. That budget is probably, a contract pharmacy realm, it's probably a few million. I mean, what's addressed for the issue before you, but I don't know perfectly in-house versus contract.
And I'm not asking that. I'm just thinking in terms of the entire 340B program, how much does that bring into the community health center?
I'd have to look it up specifically. I
That you
honestly
could get
don't.
that for us?
I don't know that I could give you the specific number, but I could give you a round number, yeah.
Thank you.
Because
Thank you,
it's,
Madam
we are,
Chair.
we're constantly audited, monthly financials.
Okay, thank you. Thanks
Yep.
for sticking around.
No problem.
All right, we are going to take our lunch half hour. If you can find someplace and to grab some lunch and be back at 1:30, please.